Bismillahirrahmanirrahim. Assalamu alaikum and good evening to all of you. Today we are going to talk about the respiratory and the ENT recall. So we are done with our respiratory session. So now I have just accumulated all the your respiratory and the ENT recalls from all the past papers. One by one I have gone through and then I have collected them. And most of them are going to be repeated ones. So I have just discussed them one time in whatever paper they have been there. And if they were repeated in the next paper or in the recent papers, then I have just skipped them because I already discussed them in this session. So most of, and say more than like 95% paper questions I am going to discuss today, because some questions were just one line question in which no even x-ray was given, or if x-ray was given then no scenario was given, and only like one line answer was there. So I have not added that because they were obvious. They have just write down the answer in the papers. So that's why those who didn't make any sense, like this one line scenario with one option or with no x-ray or just x-ray, so obviously they are not like that much to be discussed, or to be to waste time on these scenarios. Another thing I want to mention that the most of the X-rays which has been given in the recalls, they are not the actual X-rays. They have remembered the scenario, and then according to that or according to the answer, they have searched that look-alike picture of the x-ray on the internet, and then they have just put it in the previous recalls. So that's why do not, if and I have seen that, and I have also added those questions in which the scenario is different, scenario and the answer is given different, but that is not correlating with the x-rays they have given in these previous recalls, which means that these are not the actual x-rays. So I will advise you that do not waste your time on arguing that whether this is the actual x-ray or not, and x-ray is saying something else while the answer is giving something else. So they have after they have this their results, and the persons or the students who got the 100%, they marked those answers. So that's why I have just left it as such. I have not made any changes in them, and I will then tell you that how this x-ray is not correlating with the answer or the scenario. So this is one I have seen, like last time also the students were arguing on the x-rays that x-ray is not showing this, then how is this the answer? Please explain us to us, even though I have also repeatedly said that before, and again telling you that do not rely on these previous recalls again, because even we are done with the FOP and task just like yesterday and exam, and the thing is that these recalls are being repeated, there is no doubt in that, but they change the scenario, they change the option, and literally only minute changes are there. Like if the age of the child was 6 years with the asthma, and they will change it to the 3 years with the asthma, and the total answer is going to change, and the students do not notice this. They just see that okay, this is the past scenario, and all the others and scenario is the same. Scenario is totally same with same options. They just change the name. They just change the age of the patient, and that make totally different answer from the options. So, and the student did, and student asked me that you told us that this was the answer, and like that, you specifically mentioned, but I then explained them the specifically mentioned for the children above 5 years of the age. I have also taught you the asthma management for the children who are less than 5 years of the age. So this is on there. The age is given 3 years. They have changed the age of the child, so the answer is going to be now changed according to the algorithm. So these are the minute changes. Everything will be the same, they will change the age, or everything other will be the same, and they will only change one option from the your from one option, and that will also make the huge difference that now what will be the answer to this scenario. So that's why these recalls are for your practice. So take it as the practice one. Do not ratify it, or do not think that this is something so much holy or something so much like compulsory or essential that you have to ratify each and every answer, each and every question. You will go to exam and you will pass the exam. This is not like that. It does not happen like that. And if you are done with the FOB task, you must have known. If you have talked to anyone who previously attempted the AKP exam, you must have known that they do repeat the recalls, but they twist it, they change it. So that's why the concept is very important. I have given you most of all the concept regarding whether to diagnose the X-ray, which lobe consolidation or the collapse is there, almost all the other important things which are going to be there in the respiratory and the ENT. And the one to two things which were missing and which I came to know while solving these recalls, I have added in this recall session. So that's why I will again advise you, do not make this mistake of memorization or ratification of the recalls with the answers. Do not do that. Please make your concept and then just revise these your recalls according to your concept, and make the logical answers and make the logical interpretation of your scenarios and all the other things. So now let's just start with that. First of all, AKP September 2025, and the first recall is a 1 week old infant with persistent chest symptoms since birth. Doctor heard sounds on at the right side. X-ray was done. What is it is showing? Left-sided congenital lobar emphysema, left pneumothorax, left pulmonary interstitial emphysema, or primary ciliary dyskinesia. As you can see that there is a basically this is the left upper lobe basically that has been extended, or you can say that distended, and because of that this heart has been shifted to the opposite side, even though this x-ray is having the more exposure, due to which all of this x-ray is looking like the dull dark black or hyperlucent even on the right side and on the left side. So that's why we are unable to locate the exact location of this your emphysema, but this part is telling you that this is basically your left upper loop distension. It is not present in any other case, not even in the cystic adenomatous malformation. So that's, and pneumothorax also does not present like that. This is showing you, this part is showing you that this is your distension of the your left upper lobe. So this is going, and this is also the most common area or most common location for your left-sided congenital lobar emphysema. So the right option is going to be your option A. It's not left pneumothorax. Pneumothorax does not extend like that. Left pulmonary interstitial anemia does not present like that. There will be the bronchovascular pulmonary markings and the fluid and the other things will be there. And primary ciliary dyskinesia, no, this does not present like that, in which there will be the total normal x-ray, only the heart will be on the on the right side. But here we can see that this is your mediastinal shift because of distension of this right upper lobe, and that is making the heart to shift towards the right side, due to which doctor heard the heart sounds at the right side. So that's why this is most likely going to be your left-sided congenital lobar emphysema. So this is the right option. As you can see that what does it mean that in this basically one or more than one lobe of the your lung is going to be over distended or over inflated, like it is given here. Like this left upper lobe is distended. And similarly in the x-ray you can see here this is your left upper lobe distended, and if you can see in this x-ray this is your distension of the right upper lobe, left upper lobe, sorry. So this is your left-sided congenital lobar emphysema. And this is the same rare pathology characterized by the overdistension of one or more lobes of histologically normal lung. And the most common side affected lobe is the left upper lobe. And it is because of the abnormality of your bronchial cartilage, which result in the reduced or the absent bronchial cartilage, resulting in the overinflation of the affected lobe. And it can also be caused by some external bronchial compression from the various causes like abnormal vessels, lymph nodes, cyst, which will result in the air trapping and then the overdistension and emphysema. We have discussed all of this in the session also, but I am also adding almost explanation of every scenario here also, so that you don't have to go back to revise it again. At the end of the your preparation, when you are revising the recalls, you can also just revise these important topics from just revising this recall session or the PPT, and that will be more than enough for you. So the infants with the CLE can present with the respiratory symptoms soon after birth, but more commonly they present to clinicians after 1 to 2 months of the age. And the severity of the symptoms depend upon the degree of the overinflation of your affected lobe. The more severe involvement, the more severe symptoms, and they present at birth. And if it is mild to moderate, then they can present later in the life, like of 1 to 2 or 2 to 3 months. They present with the signs of respiratory distress, tachypnea, tachycardia, and the chest retractions will be there on examination. There is going to be the decreased breath sounds over the affected lobe and the shift of the apical heartbeat to the opposite side of the chest. So you can go for the X-ray for investigation, which will tell you the over distension of the one lobe. But it is helpful, but it's not diagnostic, because if it is on the left side, then it will be resembling to the, so usually the congenital cystic adenomatous malformation, which is also a close differential of this congenital lobar emphysema. So that's why whenever you have to confirm the diagnosis, you will go for the CT scan or MRI of the chest. It is the most useful diagnostic information. And the management will be depending upon the severity of the symptoms. If there are the mild cases, then you can manage conservatively with the respiratory support. And if there are severe cases, then you have to go with the surgical resection of the emphysematous lobe. Then the next recall is 8 years old boy present with high grade fever, that is 39.1 degree, and the cough and the chest tightness. He lives on a farm, and what is the most likely organism for causing this condition? On the chest x-ray, and chest x-ray was similar to this, but right on the right side there was massive in effusion was given. So if we think about, and what is the answer? Mycoplasma, staph pneumoniae, staph aureus, mycobacterial TB, or the legionella pneumonia. So the thing is that the basically your mycoplasma, there is going to be the subtle onset, and they will be gradual onset, and there will be mild bilateral or interstitial changes. It does not cause this overt effusion. Then we have the staph pneumoniae. Staph pneumoniae also causes, usually it involves the lobar lobe, and it causes the lobar consolidation. And the this one, these effusions can happen like parapneumonic effusion, small effusion, but not like this overt effusion. Similarly, mycobacterial tuberculosis, the history will be prolonged, like after 4 weeks, and with the background, like the patient is coming from Pakistan, Asia, or Africa, or something like, or any other such country, and now he's living in the UK, and there is prolonged history, and then it can cause this the massive effusion. But this is here, we don't have such information given here. Then the staph aureus and the legionella can cause these symptoms, and the staph in the staph aureus also, there's going to be the high grade fever, and the patient will be more toxic looking, and it will result into the this your the effusion can cause, but the staph aureus usually cause the loculated effusion, which is which for which we need even to go for the intrapleural fibrinolytics. And the legionella, yes, it can cause, the basically scenario is fitting in the legionnaire disease, which is caused by the legionella bacteria, because patient is living on the farm. That is a huge clue here. Staph aureus has nothing to do with the farm here. So when we get this clue that the patient is living on the farm and now presenting with like sudden high grade fever, cough, and specifically chest tightness, and on the extra there is effusion. So this is going to be towards your more likely the Legionella as compared to Staph aureus, because Staph aureus has nothing to do with the form. And it's also Staph aureus will also take like days to develop and go on to into this effusion. And the Staph aureus effusions are mostly loculated, and Staph aureus pneumonia most likely to complicated by the pneumatoceles as compared to the effusions. So, the according to me, and if whatever I have researched on the sign and symptoms and their differences, I think this is going to be your Legionella pneumonia. But only one thing is that Legionella is not much common in the children. It is more common in the older adults, as well as in the patients who are have some immunocompromised disease, which in which they are more prone to get this infection. But as the nothing else is fitting in, so maybe the scenario is incomplete. Maybe the child has some underlying other condition, or some other clue is given in the scenario which can make the option different. So that's why whenever if you get such question in your exam, be logically go along with the symptoms, that what how mycoplasma can present, how staph pneumoniae can present, how staph aureus, and whether they are correlating with all the clues that has been given in your scenario or not. Like here, the form is not correlating with any one of them except the Legionella, because it can be transmitted from the soil that is contaminated with this Legionella bacteria. So that's why the option E seems to be more appropriate here. So this is the answer most likely. So Legionella disease is basically, it is a severe form of lung infection called pneumonia, and it is caused by the Legionella. It is spread from the contaminated water as well as from the soil. And it begins with the headache, with the sign and symptoms of headache, muscle aches, high grade fever. Usually it is present, cough with the mucus, and sometimes blood can be there, shortness of the breast, chest pain, nausea, vomiting, and diarrhea can also happen with the passage of the time, and confusion or the other mental changes can develop if it remains untreated. And radiological appearance often lag behind the clinical picture. There can be deterioration on the imaging despite clinically patient is improving, but the imaging can get worse, like they can develop this proliferation. And the proliferations can be common, and they are occasionally seen even in the absence of any other lung infiltrate, and the treatment is with the azithromycin. So this is the just basic, but the thing is that it is more common in the adolescents as compared to the children. Only this thing is going to opposite to this scenario. Maybe the age is 18 years they have want to give or something like that. So in this scenario, whenever you get in the exam the complete scenario, please look for all the signs and symptoms and correlate with all of these your organism that has been given, and then according to that you can go with the right option. And that's why I will again say, do not ratify the answer. Go logically and then interpret your findings of the scenarios, and then you can mark the right option. So 8 years old boy asthmatic on beclomethasone 200 microgram BIBD, and what will you tell parents about its effect on the growth? So there is going to be the decreased growth velocity but normal mid-parental height, decreased growth velocity but final height less than the mid-parental height. After 1 year treatment, the patient needs bone density scan and no effect on the growth, and the final height can be predicted by the mid-parental height. So you see, now there are the two differences. One scenario is given in the endo in which the patient is taking systemic steroids. Here, this is the asthma. Patient is taking inhaled steroid, and that is also mild. Less than 200 is going to be your mild, low dose inhaled corticosteroid. So patient is taking low dose inhaled corticosteroids. That is not going to affect much your height. So when you you get this scenario, such scenario, you do not see that whether systemic steroids patient is taking, because you are all familiar with the systemic steroids like in the congenital adrenal hyperplasia in the endo session, and in which the height will be decrease, the final height is going to be the decrease, and there will be huge effect on that. You need to tell this to your parents. But this is the difference that, and when you get the such scenario, you do not focus on that what has been given. You just think steroids has been given, okay, now the height should be less than the normal one, the ultimate height. So thing is that you need to have to be very concentrate on the scenario, that what they are telling you and what then they are asking you. So this is the asthmatic boy who is on inhaled corticosteroids. Inhaled corticosteroids does not lead to you immunocompromise, or does not lead to the much effect, or does not cause that much toxicity. And this is only low dose inhaled corticosteroid. Yeah, inhaled corticosteroids initially can, when you start it, then the body is adjusting according to that. In the initial 1 year or 2 year, they can cause like mild 1 to 2 centimeter decrease in the growth velocity, but ultimately the patient is going to be the normal, and they will achieve their normal mid-parental height. So make sure that what is written in the scenario, whether it's systemic steroids or it's inhaled steroid, and then in the inhaled steroids it's low dose, moderate dose, or high dose. Yeah, high dose can affect largely, but the low dose and the moderate dose does not affect that much. So the right option here will be that decreased growth velocity will be there initially, but ultimately the patient will achieve the normal mid-parental height. So the right option here will be option A. So inhaled steroids have only mild impact on the height initially, but ultimately achieve the normal height in contrast to the systemic steroids. Then which of these following chest X-rays findings require follow-up with the imaging? It's bilateral perihilar lymphadenopathy, unilateral perihilar lymphadenopathy, pleural effusion, left lower lobe collapse, or the left lower lobe consolidation. Now, this is again the scenario in which I cannot find something definitive, because there's a tie between the two options. Perihilar lymphadenopathy does not need the follow-up this X-ray when you are treating, if it is a case of your TB, or if it's unilateral, then again you don't need much, you don't need the follow-up chest X-ray. Similarly, in case of the community-acquired pneumonia causing the consolidation, you don't need any follow-up on the chest X-ray on the follow-up. But there are the two conditions in which you need the chest X-ray on the follow-up. It is pleural effusion as well as it is your collapse. It is written in the guidelines also that as well in the pleural effusion as well as in the left in the your collapse, you have to go for the whenever you will discharge the patient, then on follow-up you have to go for the chest X-ray. Like this is the discharge follow-up for the pneumonia, radiography follow-up if the patient is having ground pneumonia or the patient is having collapse or there are the persistent symptoms. So if the patient has collapse and you discharge and now patient is coming to you on the follow-up, then you have to go for the chest X-ray. Similarly, this is for the pleural effusion discharge and follow-up. Patient was a known was treated with the for the pleural effusion. You discharge and now on the follow-up, arrange review by the respiratory pediatrician and initial appointment 6 weeks after the discharge, and the chest X-ray need to be done on the arrival of the patient. So for the both pleural effusion as well as for the collapse, you need this your the follow-up. So option C and D both are right, but I don't know this scenario was only like this one line scenario or there was anything other was also given in the scenario which can lead us to more like clue toward whether it's a pleural effusion or the collapse. But the thing is that both D and the C are right. I couldn't find any specific your indication whether it's pleural effusion or collapse in which if we have to choose among them, then what we will choose, because everywhere in the guideline for both of them, whether it's your collapse or the effusion, they have mentioned that you need to do the follow-up chest X-ray on the follow-up. So both C and the D are right until unless if scenario has some other findings which can tell us to differentiate between C and D. So the right option here both is the pleural effusion as well as the collapse, and these are the guidelines which I have given you the evidence from both like from the guidelines. Okay, then we have a 3-year-old boy was brought by his grandmother. He is not in distress and has mild fever. On examination, there is periauricular lesion, which investigation will guide the management. It's a case of mastitis. Like here, you can see that this is your redness and the swelling is there, and your this auricle has been anteriorly displaced forwardly. So CT head and neck, blood culture, interferon gamma release assay, hearing test, or take biopsy from the lesion. So only thing that is advised is the basic CRP, CBC, and blood culture, but that does not guide the management. That is just for your like a basic so that you can see the response of the patient. If within 24 to 48 hours you have started the treatment and the patient does not get clinical improvement, then you need to go for the CT head and neck of the patient. So that's why the most important investigation in the acute mastitis that is going to guide further management, that will be your CT head and the neck, because on that you will see that whether there is any subperiosteal abscess is there or not. If there, then you will go with the drainage surgical, and if it is not, then you will continue the antibiotics, and then again you will repeat it and you will see for them all those things. And similarly, it will also tell you about the intracranial extension or any other involvement of that. So the right option here is the CT head and neck for the acute mastitis, which is going to guide you for the further management. All other are non-specific. So this is the right answer here. Okay, a preterm baby with a history of the diaphragmatic hernia that was surgically corrected. After she started feeding with the this NG tube, developed respiratory distress and a milky pleural aspirate is there. What is the most likely cause? Injury to the thoracic duct, pleural effusion, or remove a nasogastric tube. So in the pleural aspirate, it can't be your just nasogastric tube which has the feet which it cannot just go into the pleural space without any reason. This is not the cause. Pleural effusion will not be milky. Empyema will be pussy like whitish, you can say, but when they mention that it is a milky pleural aspirate, that is your injury to the thoracic duct that is leading to the thorax, and we also have a history of the surgery here, and it is most commonly present after any trauma or any surgery. So in which you get the injury to the thoracic duct that will result in the your accumulation of the chyle, that is the lymph in the pleural cavity, and that will result in the chylothorax. For the pleural effusion, we don't have any clue here that the patient has pneumonia or such symptoms which are leading to this pleural effusion or the empyema. So right option is the injury to the thoracic duct. This is the right answer. So in thoracic duct injury is basically damage to your thoracic duct that can cause it to leak. And if it leaks into the space around the lungs, like pleural cavity, that is result in the coilothorax. And the coil, basically this limb contains the triglycerides and it is white milky in the color. And it is very common secondary to any trauma, surgery, or any neoplastic disease. And here we have the second cause, that is the surgery is done for the diaphragmatic hernia. So that is a result into the damage to the thoracic duct, and it will result into the this chylothorax. And the treatment is you have to drain it. A known case of the obstructive sleep apnea was admitted for a polysomnography study, and after 30 minutes, the oxygen saturation dropped to 85. What would you advise the nurse? Continue the study without oxygen, continue the study with oxygen, advise the nurse to wake the patient if oxygen saturation drops below 80%. So we talked about that for the obstructive sleep apnea, the polysomnography is basically the diagnostic one. It is the gold standard to diagnose this obstructive sleep apnea. And what does happen, basically what we are looking for, that basically whenever the patient with the obstructive sleep apnea sleeps at night, there are the periods of the desaturations in which the saturations drop that result in the hypoxia. But and that is going to disturb the sleep of the patient, and because of that he will be irritable, disturbed sleep, and in the daytime there will be somnolence. So, in that, this is the normal thing. Patient is living with this thing, and you are just now checking it, confirming it. And once you will confirm it, then you can start with the management of this obstructive sleep apnea. So, in the polysomnography, when you get this oxygen saturation drop to 85%, this desaturation, you don't have to do anything. You don't need to attach the oxygen. You don't need to wake the patient. Nothing you have to do, because what you are doing, basically, you are checking the periods of the desaturations, at how long it will be, how many times the oxygen saturation is dropping, and what is the extent of this desaturations. And along with that, many other things are being recorded, like what is the level of the carbon dioxide, along with that, what is the heart rate, what is the respiratory rate, many things. Basically, in the polysomnography, you are recording throughout the night. So that's why you don't have to do anything. You just will be there. You will be monitoring those, and you will just monitor or record these desaturations, their frequency, and their the extent. So the right option is there. Here is the option A, that you will just continue the study without oxygen. You don't need to attach the oxygen. You don't need to awake the patient. So right option here is the A, that continue the study without oxygen. Now the AKP May 2025. X-ray of an 18 months with cuff and the soft bilateral lower V's. No one got 100%. Okay. So basically this is the X-ray. They say that was 18 months old, and with cuff and the soft bilateral V's. If it is an 18-month, so if we can see that there is mediastinal, right mediastinum, because it is more than one third of the AP diameter, or if basically we have to see at this knuckle, aortic knuckle level. It is more than one third of total transthoracic distance, or it is more than 8 centimeter, then we label it as the wide mediastinum. But the thing is that otherwise, if we see the other thing, hilar lymphadenopathy, no, it's not there. Interstitial infiltration, I cannot see any interstitial infiltration. Posterior rib fracture, no, there is no posterior rib fracture. I cannot see here anything. So most likely option is the wide upper mediastinum. Now, one thing to need to know that up till 3 years of the age, this wide mediastinum is basically the thymus shadow. The borderline is 2 to 3 years, or somewhere it is also written as the 12 months. Like after 1 year, this thymic shadow just goes off. So, but we have taken it as the 3 years. So if this is 18 months, then it can be just normal. Cough and the soft bilateral V's, it can be just simple. You can say the bronchiolitis and viral infection. But if X-ray was actually there, and if the scenario is actually like that, I don't know what to say. But if we just see the X-ray, then on the X-ray there is upper mediastinum, so that's why the answer is option A, because none of the other option is right according to this X-ray. So that's why I'm telling you that whatever scenario they give you, you have to correlate with the X-ray, and then you will answer that. And remember that these scenarios are incomplete, and these X-rays are not actual one. So just whatever the concept you can take from this scenario and the x-rays, just take it and then just move on. So if I just look at this your x-ray, there is wide upper mediastinum. So that's why I will go with the option A, wide upper mediastinum. When we say that this is a wide upper mediastinum, when the mediastinum width is less than 8 centimeter on PA view, that is the normal. So when it is more than 8 centimeter, then at the level of the aortic notch. So when there is at the level of the aortic notch, if it is going to be more than 8 centimeter or more than one third transthoracic distance, then we label it as the wide upper mediastinum. Otherwise, this is normal. Less than 8 centimeter and less than one third transthoracic distance, this is the normal one. And 3 years, up to 3 years, there is thymic shadow, which is giving the appearance of this wide mediastinum. Above 3 years, it is mediastinal mass. So if above 3 years you get this mediastinal upper wide mediastinum, then this will be your mediastinal mass. So you need to look that when you will say that this is upper wide mediastinum, and then according to the age of the patient and the symptoms, if they're also fitting in the mediastinal mass or not. X-ray of the chest baby, 18 months, has been well presented with the upper respiratory tract infection for 2 days, and now sudden shortness of the breathing, wheezing, and decreased air entry on the right side. So what is your best action? CT chest, chest ultrasound, urgent referral for the bronchoscopy, or insert chest drain on the right side, or there is going to be the nebulizer salbutamol. So patient was 18 months old, has been well, now just presented with the 2 days of upper respiratory, and there is sudden onset of shortness of the breathing, and there is wheezing and decreased air entry on the right side. So you can see that this is your basically, if you see that this right lung is basically hyperinflated as compared to the left lung, if you see the volume of the lung. And then we can see that there is a hyperlucent, this your area is right lung is there, and there is also decreased air entry and the wheezing also on this side, and because of that your this heart is basically shifted towards the left side, more on the left side. So most likely this is a case of your foreign body. That's why we will go for the urgent referral for the bronchoscopy. And you can see the basically even the lung margins there. So when you get, even though this is not a typical picture for the foreign body, but on this scenario, as there is only one right-sided decrease air entry, wheezing, shortness of the breath, and that is sudden in onset, and the age is also telling you that this is 18 months. So that is more likely going towards your foreign body. And 2 days of upper respiratory tract infection is not leading to the pleural effusion. If we think that this is the actual X-ray or the pneumonia or the pneumothorax, there is no reason for that. So only thing that is fitting in according to the scenario, and we can say this is the hyperinflated lung present on the right side. That is your foreign body. So option C most likely is going to be urgent referral for the bronchoscopy. And in the exam or previous recalls answer was this one. They have given that this was a X-ray of the foreign body, but this is not typical one because they have taken it from your just internet. So this is the urgent referral for the bronchoscopy because most likely it is your foreign body. And in foreign body, basically, there is collapse or the hyperinflation of your affected loop. Like here, it is the left-sided involved, and the mediastinal shift to the opposite side is also present in those cases. Then the 6 months old presented to emergency department with history of the worsening inspiratory stridor, which started at 3 months, and now his respiratory rate is 40 per minute, and there are intercostal recessions. What is the most likely diagnosis? It is laryngomalacia, laryngotracheobronchitis, or it is vascular ring, bacterial tracheitis, or foreign body inhalation. So the inspiratory stridor department with history of started at the 3 months of the age. Before that child was okay, so it can't be your laryngomalacia, because in laryngomalacia usually in the first and the second week of the life the patient started to have the symptoms, and while in the bacterial tracheitis is acute within 1 to 2 days, foreign body also 1 to 2 days, the laryngotracheobronchitis also within 1 to 2 days. So these are the acute infections. They do not present like that with chronic history. This is that patient is now 6 months old, and since the age of 3 months, he is having this inspiratory stridor, which is worsening, and now the the intercostal recessions. So this is most likely a case of your vascular ring, which is also a congenital abnormality that causes this stridor, and along with that, there is also the dysphagia. So this is a vascular ring because the rhingomalacia symptoms start at 2 weeks of the age. Vascular ring symptoms typically start at 3 months of the age, and then they develop the dysphagia at 6 months when they started the solids. So this is again the same thing which we have already discussed in your the session. Vascular ring occurs when the aorta and its branches form a complete ring around the trachea and esophagus, and the presentation age is around 6 to 7 months, specifically for dysphagia. But they can start the instridor and the respiratory distress start as soon as 3 to 4 months of the age. Noisy or the labored breathing, especially with eating, difficulty swallowing in child reads milk or the other food. Dysphagia, child feels like something is stuck in the throat, keeps choking or feeling like he or she is choking on food. Persistent cough and acid reflux can be there. You can go for the diagnosis. We go for X-ray, MRI, CT test, and the barium swallow. And the ultimate management is going to be the surgery. Okay, 12-year-old fairly referred to outpatient clinic with expectorant wet cough and the cleared sputum, received 2 short courses of the amoxicillin and not improved. There is history of the recurrent otitis media and the rhinitis on the examination, height and weight on 50th centile. Patient is afebrile and pink with no focal sign in the chest. Not the same picture. Okay, so it is superior mediastinal mass, hilar lymphadenopathy, right middle lobe pneumonia, right lower lobe pneumonia, right middle lobe collapse, or increased bronchial thickening is there. So it can't be right superior mediastinal mass because mediastinum is not widened here, it is normal. Hilar lymphadenopathy is there, like here in the right side, and also, yeah, right side, there's some hilar, you can say that. Otherwise, no. Increased bronchial thickening, I cannot see anything like that. You can see these are the bronchi and they are not thickened. If they are thickened, they will be more like thickening of the bronchioles will be there. Then the right middle lobe pneumonia, okay, this one is also not there. Right middle lobe pneumonia, yes, this can be a right middle lobe pneumonia. You can see this is your horizontal fissure and your right-sided heart border is obscured here. So this is most likely your this right middle lobe pneumonia. It can't be right lower lobe pneumonia because in right lower lobe, this hemidiaphragm left side will be obscured. Along with you will get the normal heart border. This is the difference between right middle and the right lower lobe pneumonia. That is not there. It is not right middle lobe collapse because then you will get a triangular opacity here, and that is also not there. So most likely option here is your right middle lobe pneumonia. I think they in the exam they asked for the 2 options, so that's why the answer was hilar lymphadenopathy and the right middle lobe pneumonia. But if you want to, if they ask for one option like it is happening in the nowadays in the exam, then the right option here will be only one option will be right middle lobe pneumonia, because this is just like that. You see that there will be the intact, your horizontal fissure will be intact because the right middle lobe is located below the horizontal fissure. Then there will be a loss of your cardiac border here, just like that. Loss of cardiac border, right middle lobe is next to the right heart border, which become obscured, and the homogeneous opacity in the middle lobe will be there. So this is the typical your right middle lobe pneumonia, and it is not right lower lobe because in right lower lobe, your right hemidiaphragm will be obscured along with your right your cardiac border will be intact. It is not lost. So this is the difference between right middle lobe and the right lower lobe pneumonia. So the right option here is right middle lobe pneumonia. One option, and if they ask for 2 options, then the also hilar lymphadenopathy. A 12-year-old girl presents with cough and shortness of the breath, received 2 courses of amoxicillin with no improvement. On examination, weight and height on the 50th centile, pink and the wet cough, no focal lesion on the auscultation, X-ray done. What is the finding in the X-ray? Left lower lobe consolidation, right middle lobe consolidation, bronchial valve thickening, hilar lymphadenopathy, or nematocele. So if you can see that in this X-ray, there is basically obscuration of your left-sided hemidiaphragm. That is telling you along with intact your heart border. So this is a case of your left lower lobe pneumonia as compared to There is no nematocele. We can see there is no hilar lymphadenopathy. Yeah, slightly we can see on right side, but it's not significant. No bronchial valve thickening. Right middle lobe, no, it is not right middle lobe consolidation because your heart border is intact and you cannot see any horizontal fissure here. So this is going to be your left lower lobe consolidation because you can see that your left heart border is intact, along with there's a loss of your left hemidiaphragm that is typical for your left lower lobe consolidation. So option A is right here. So in the left lower lobe, what happens? A homogeneous opacity behind the heart will be there, and the left heart border was visible. It will be intact, along with loss of left hemidiaphragm contour. Your basic thing is that in the lower lobes pneumonia is that your diaphragms, either it's right or on the left, they become obscured. That make it differentiate from the middle lobe on the right side and from the upper lobe on the left side. So this is your middle left lower lobe consolidation. Chest X-ray of 13 years old Sudanese boy came on a visit to the UK. 6 weeks history of the cuff and chest tightness. What is the diagnosis? Non-Hodgkin lymphoma, foreign body, pulmonary tuberculosis, and the strep pneumonia. If we see the scenario only, this is a Sudanese boy and who came to visit UK, and there is 6 weeks history of cough and chest tightness. So this is all going towards pulmonary tuberculosis. So on this scenario. But if you see the X-ray, if they tried to make it like TB, or I don't know, they wanted to make it like as a non-Hodgkin lymphoma presenting with a mediastinal mass. But the thing is that if we see this is can be a case of this is a pleural effusion is giving there, which is causing the mediastinal shift, and you can see that here. But there is even no mediastinal shift. I cannot see any because this is all pleural effusion that is there, and slight lung borders here in the upper lobe is there. So most likely it is a case of, even I think in the previous recalls they have marked it as the non-Hodgkin lymphoma. Maybe in the scenario or in the X-ray there was upper wide mediastinum leading to telling you that this is a case of your the mediastinal mass, so that's why non-Hodgkin lymphoma. But according to the scenario, it is nowhere even close to the lymphoma. With the Sudanese boys, that is a country where the TB is going to be there. Now visiting UK with 6 weeks history, that is straightforward your pulmonary TB. And also this, even if I look at the X-ray, this is all the pleural effusion causing the mediastinal shift to the opposite side. So most likely the answer is going to be here your option C, that is the pulmonary tuberculosis. Okay, child pneumonia and not responding to the treatment after 48 hours. Second ultrasound showed loculated pleural effusion. Description was given, no photo. How will you manage? Chest drain with the fibrinolytic, or the chest drains, or the antibiotic. So for the loculated effusions, we always have to go with the chest drain with the fibrinolytic. So that's why the right option here will be option A. Chest drain with the fibrinolytic will be there. So it is when we go for the intrapleural fibrinolytics, where it is indicated if the thick fluid with the loculation or the pus is there in case of pleural effusion. So they have given you the loculations, so that becomes an indication to go for the fibrinolytics. So we will pass the chest drain and we will start the fibrinolysis. So right option will be option A. A 4-year-old child with a history of the viral infection 6 weeks ago, after which he developed the hyperinflation, generalized wheezing, and the clubbing. What is the diagnosis? Bronchial asthma, bronchiolitis obliterans, and the bronchiectasis. So bronchial asthma does not cause this clubbing. It can be bronchiolitis obliterans or bronchiectasis. But for the bronchiectasis, you need to have the repeated chest infections or some underlying disease, immunodeficiency, or inherited disease that resulting into the repeated chest infection. So that is also less likely. But the only thing which is left is that the bronchiolitis obliterans, it can happen after an episode of the bronchiolitis or the viral infection and that result in the permanent narrowing of the bronchioles. And as the patient is 4-year-old and he has history of the viral infection 6 weeks ago, that is typical for the bronchiolitis obliterans, in which like few weeks ago the patient has history of some infection, viral infection, and after that then again presented with this the chest infection, you can say, or the wheezing and all these things, which are going to be the recurrent one and not responding to the usual treatment. And with the passage of the time, if it remain persistent, then the patient develop clubbing because of the persistent hypoxia. So that is your right option will be option B. That is the bronchiolitis obliterans. So bronchiolitis obliterans is the inflammation in the small airways, that is the bronchioles, like bronchiolitis, and obliterans means the permanent narrowing. So it is a chronic obstructive lung disease which is caused by the inflammation as well as the fibrosis of the bronchioles that result into the partial or the complete obstruction of your bronchial lumen, resulting in the permanent narrowing. And that will then result in the recurrent these infections. And the bronchiolitis obliterans is caused by injury to the lungs, and the most common cause is adenovirus, but can also occur after RSV, influenza, and parainfluenza. This is one thing I want to correct, that when I was again solving these recalls and I went into the further deeper and digger. So the in our session we talked about that the bronchiolitis is most commonly caused by the RSV. Yes, it can be caused by the RSV, but the most common cause has been given in the different researches in the different you can say the criterias and the different the leaflets as well of the UK. It has been given as the adenovirus. Yeah, in 1 to 2, it is given as the most common is RSV, but the you can say 80% other literature data is telling us that the most common cause of the bronchiolitis obliterans is adenovirus. So that's why I have made changes here. And I will also make the change in the respiratory PowerPoint PPT, and that will again be uploaded. So just make it correction here that the bronchiolitis obliterans, the most common cause is post-infectious. It happens after the adenovirus infection, but it can also occur after RSV, influenza, even parainfluenza virus. And there is always a previous severe viral respiratory infection history 4 to 8 weeks ago. And then the patient present persistent dry cough, which is unresponsive to bronchodilators, difficulty in breathing, fever, and tachypnea, which result failure to resolve. And the repeated episodes of these symptoms will be there. And on the chest X-ray, there will be hyperinflation, patchy pruning of the vascular markings, and on the CT, you can see thickening around the bronchioles or the honeycombing. And the treatment is that you have to start the systemic steroids, and to these steroids the patient started to respond. X-ray with the scenario of the sudden shortness of the breathing and upper respiratory tract infection. There is history of the home decoration. So it is foreign body, congenital cystic adenomatous malformation, pneumothorax, or the chemical pneumonitis. As you can see that there is hyperinflation of the left side of the lung, and it is not cystic adenomatous malformation. It does not involve the whole lung, and it is also not the chemical pneumonitis which present with the infiltrates. It can be foreign body or it can be pneumothorax. The thing is that in the how we differentiate its foreign body and pneumothorax. In the foreign body, bronchovascular markings will be visible with the hyperinflation of the lungs, but in the pneumothorax, the bronchovascular markings are totally absent. Like here, only mild, I think this one area I can see, otherwise all the other where the bronchovascular markings are absent. So this is not a typical scenario or the X-ray, I will say, but the scenario is going towards the foreign body because there is sudden shortness of the breathing with history of the home decoration, which means the patient has ingested some foreign body, and that result in the sudden onset of shortness of the breath. So this is most likely going towards your foreign body, even though this is not a typical picture, because in that there will be hyperinflation of the lung along with the more prominent vascular markings will be there. So that's why always correlate your scenario with your chest X-ray. Why I am not giving much importance to these X-rays, because these are not actual X-rays. They have taken it from the internet and then they have just attached it towards with the scenario. So scenario is something which they have recalled also, which is also not that much reliable, but still it's a good thing that they have been able to remember it, and then they have given us something to rely on. So most likely it is a case of your foreign body, depending upon the scenario and also correlating it with the your this one the X-ray that is left your hyperinflation of the left lung. Upper respiratory tract infection cannot cause sudden onset of the like distress. Yeah, if it's pneumonia, patient is on the respiratory support, then it can result into that. And also, the pneumothorax has nothing to do with the home decoration. Home decoration means patient has foreign body inhalation, and that result into the like hyperinflation of your lungs, not the pneumothorax. So the option A is going to be your most likely right option here. Then we have the AKP January 2025. Okay. So 9 years old child presented to accident and emergency department at ER 6 hours of the left tibial fracture with respiratory difficulties and raised JVP and the chest X-ray findings. What is your diagnosis? It is pulmonary fat embolus, heart failure, sickle cell crisis, pneumothorax, or the hemothorax. It can't be these all of these. Neither it's pneumothorax, hemothorax. There is no hyperlucency is there. Either it can be pulmonary fat ambulance or it can be heart failure, because the picture is like that. These fluffy infiltrates are there, which we can see in the pulmonary edema as well as in the your this pulmonary fat ambulance. But the thing is that scenario is going towards your tibial fracture. So whenever there is a long bone fracture and after that the patient presents with a sudden onset of the respiratory difficulty, is going to be towards your fat ambulance. So this is most likely a case of your option A, pulmonary fat ambulance, ambulance, sorry, ambulance. And it can't be heart failure, because for that the heart will be very greatly enlarged, but here the heart seems to be of the normal size also, so less likely heart failure. And as in the background of the tibial fracture, this is going to be your fat embolus. And the this is the right option here, pulmonary fat embolus. And the fat embolism, it occurs typically 24 to 72 hours after long bone fractures, any orthopedic surgery or any trauma. And the fat globules, basically from bone marrow, they enter the circulation, then they lodge in the pulmonary capillaries and they cause the inflammation and the hemorrhage. On the chest X-ray, you will see the bilateral diffuse patchy opacities which resemble the snowstorm or the fluffy patterns due to pulmonary hemorrhage or the edema. So you can see these patterns like a patchy snowstorm or the fluffy pattern. And you see the heart is also of the normal size. And or it can be ground glass or the alveolar infiltrates, and the patient has the normal heart size, which differentiated from the pulmonary edema. And also with the history of, always there will be any history of long bone fracture, any surgery, orthopedic, or any trauma. Then we have the following is an X-ray of one of old child with respiratory tract infection who received oral antibiotics without any improvement. What is the next investigation? Either it's ultrasound chest, CT chest, fluorescences, or the blood. So if you can see that this is totally white out lung on your right side with also slight mediastinal shift towards the opposite side. This is a case of your pleural effusion. So it is causing your homogeneous opacity with the obliteration of your cardiophrenic as well as the costophrenic angles. So this is a case of your pleural effusion, and the next investigation for the pleural effusion is going to be the ultrasound chest, because ultrasound sound chest is going to confirm this pleural effusion, and then it will help us to make the differentiation whether it's loculated or not, and for the insertion of the chest drain. So this is a case of your option pleural effusion. So option A is the right. We will go with the ultrasound chest. And also the respiratory tract infection, which is not improving with oral antibiotics. Now we need to investigate for the pleural effusion. That is also going to, scenario is also going to watch with this ultrasound pleural effusion. So small steroid pleural effusion and parapneumonic effusions can occur in children with pneumonia, but they also resolve once pneumonia is treated. But we need to investigate for the effusion if there is still persistent pyrexia or patient is unwell 48 hours after the treatment started for the pneumonia. And for that, the confirmation, we will go for the ultrasound scan to confirm the presence of effusion, then to differentiate between simple and the complicated effusions like loculations or the heterogeneous material, and also to localize the effusion at the time of the drain insertion. So we have to go for all of for all of these, we need to go for the ultrasound. That's why it's more sensitive as compared to the chest X-ray. That's why we always select the ultrasound for pleural effusion. And on the chest X-ray, there is going to be the diffuse homogeneous opacity. You can see that here. And there is blunting of the costophrenic and the cardiophrenic angles, as you can see here. And mediastinal shift to the opposite side, like trachea has been shifted towards the opposite side. And if it is small, then the meniscus sign is also going to be there, which is the curved upper border of the fluid level. Newborn on the routine examination, heart sounds heard on the right side. Baby is not distressed. What does the chest X-ray shows? Dextrocardia, CLE, or it's your tension pneumothorax. If you can see that again, this is your the distension of your upper lobe of your left side, which has shifted the heart towards the opposite side and as well as the trachea. So this is a case of your congenital lobar emphysema. Option B is going to be the right one here. Neonate on the ventilator. He was well and then deteriorated. SpO2 is 90% of FiO2 0.6. Trans illumination test was done, which was negative. It is done. It is done to rule out the pneumothorax. So it means that because when the patient is on ventilator and there is sudden deterioration, there can be the basically dope mnemonic we have to use it for displacement of the tube, obstruction of the tube, or it can be pneumothorax, or it can be equipment failure. So they have done that, the transillumination test, and the pneumothorax is negative. And the most recent ABG shows PCO2 of 10.8, which is quite high because normal is 4 to 6. And the PO2 is 5.8, which is decreased because normal is up till 9 to 12. So your PCO2 is increasing and pH is low, which means leading to acidosis. So PCO2 is increased and your PO2 is going to be decreased. So when they are going into the opposite direction, then the parameter which we have to change is the PIP. And we change the PIP in the same direction your PCO2 is going. And here PCO2 is going upward. So we will increase the PIP. So this is going to be increase the PIP. That will be the right option here. First thing we need to see whether PCO2 and PO2 are going in the same direction or in opposite direction. If they are going into the same direction, then we change the PEEP. We change this PEEP. But if they're going in the opposite direction, then we change the PIP and we change it into that direction in which the PCO2 is going. And here the PCO2 is increasing, so we will increase the PIP here. So that will be the right option, increase PIP. And this is the same thing which we have given here, that this is the one. If both PO2 and PCO2 in opposite direction they are going, then we change the PIP, and we change the PIP in the same direction your PCO2 is going. So here we have increased the PIP. And if they are going into the same direction, then we change the PIP and we just go opposite of the PO2 and PCO2. And if the PO2 is changing, but the PCO2 is normal, then we then change the FiO2 only. And if your PCO2 is changing, but your PO2 is normal, then we change your respiratory rate or ventilatory rate. So these are very, very important. If you just remember these four rules, then it's very easy for you to change or to mark the right option for the ventilatory setting. 2 years old boy passed his neonatal hearing screening, has history of 3 times bilateral otitis media, now presented with the speech delays and hearing difficulties, already referred for the speech and language therapy, has hearing loss for high frequency more than 70 decibel. What is the next action for the management? So option A, refer for consideration of hearing aid, refer for grommet insertion, speech and the language therapy, or urgent refer for the ENT. So here the patient is having 3 times bilateral otitis media and already has been referred to speech and language therapy, but still it is delayed and have quite high frequency, basically 70 decibel. So it means that this is because this is affecting the speech delays and hearing difficulties are there. So we need to go for the consideration of the hearing aid in this case, because it is quite high, like it is coming into this severe category of this hearing loss. If it is mild to moderate, then we can still like up till 40 decibel then we can just go with the grommet insertion or something like that, and it's not affecting the speech and delay. But when you get this severe loss with this your affecting the patient's daily life with speech and all these things, then we need to go for the consideration of this hearing aid here. So referral for the consideration of hearing aid. This is just for the grommet insertion. Basically, they have given usually students ask for indications for grommet insertion. So I've added these things. And here you see a confirmed diagnosis of persistent otitis media effusion with the hearing level in better hearing of more than 25 decibel or worse on two separate occasions 3 months apart. If this is the thing, then we will go with the grommet insertion. Here we don't have any persistent otitis media effusion. It is just like they have given that 3 times otitis media, and the hearing loss is there, which is affecting quite greatly. It is affecting the speech, and even they have been referred for the speech and language therapy. So most likely, and with severe hearing loss, that is about like 70, because above 90, it becomes a profound hearing loss. So that is most likely going towards your this one uh, for the refer for consideration of the hearing aid, because it is the usually we have the conducting hearing deafness in case of this otitis media with effusion. So option A is most likely right option here. 8 years old boy presented with the chest pain and the throat tightness increase after exercise. Strong family history of the atopy. On examination was vitally stable, and the cardiovascular and the respiratory examination were all clear. Couldn't find a similar pic, but it was an X-ray of mediastinal mass, small on both sides of the trachea, but more to the right side, and what is most likely diagnosis. So as they already told you that the in the this is this they have taken from the internet, in which there's mediastinal mass you can see there. So they said that in the exam there was mediastinal mass in the picture on the both sides of the trachea. So that is the right, most likely right option. Option A, that is the superior mediastinal mass. Preterm 30 weeks, oxygen dependent, admitted at 3 months with bronchiolitis and at 6 months with the fine crackles and the low oxygen causative organism RSV, adenovirus, pertussis, and the parainfluenza. So the patient was preterm and was oxygen dependent. So most likely the patient has underlying chronic disease of the lung BPD, bronchopulmonary dysplasia, and at 3 months the patient developed the bronchiolitis. So that get resolved. And now at 6 months, patient present with fine crackles and still having the low oxygen saturations. So this is most likely when the patient already have some pre-existing lung disease and he got the bronchiolitis, which means viral infection. Then after that, the patient is having these fine crackles and the low this oxygen. So most likely now the patient has developed this scenario or this case of your, you can say, the bronchiolitis obliterans, and this is, and the most likely option for that, I think, is going to be with the adenovirus, because the RSV will again, if it is again a case of RSV, then it is going to cause the your just the wheezing. And but here we have this fine crackles along with this persistent low oxygen. So most likely it is a case of adenovirus, just like if we considering it as the bronchiolitis obliterans. It can't be pertussis, it can't be also the parainfluenza, because most common is either adenovirus or RSV. RSV should cause this fine crackles and the other, wheezing and the other things. But here, I think this is with crackles and low oxygen, it is mostly going towards the adenovirus. Even though the scenario is incomplete, we don't have enough information what happened at 3 months, now at 6 months, since when the patient is having these fine crackles by low and the low oxygen, and what else is going on. So just whatever I have understood that, like with the preterm and then one episode of bronchiolitis, and now VZ episode, and now at 6 months it's going to be the crepitations and low oxygen. So I think this is most likely going towards the adenovirus as compared to the RSV. But if we get the full scenario, then maybe we are able to explain it more confidently and the more with more logical explanation. Then we have the AKP September 2024. 5-month-old baby had passed the neonatal hearing screening, and he presented today with his parent who have a concern about his hearing. What is the best test to be performed? Distraction test, pure tone audiometry, visual evoked potential, autoacoustic emission test, or auditory brainstem response. When the patient for the neonatal hearing screening, the first test which we go for is the autoacoustic emission test as a first line. And if the patient has passed and again the patient present to you because of any concern, then within this 6 months of the age, then that is going to be second line test. We will go with the second line testing, and that is usually the auditory brainstem response. So the option E is going to be there. All the above three, we use it above 6 months of the age. We do not use it in the and less than 6 months. In the less than 6 months, we use either the autocaustic emission test or the auditory brainstem response. So once your autocaustic emission is done and you need to repeat the hearing test, then you will go with the auditory brainstem, which is second line. But if no testing has been done at all in the neonatal age, then the first line will be, you have to go with the first line, that is autocaustic emission. But here, as the patient has already passed the neonatal hearing screening test, that was the autocaustic emission, and now we need to go for the, again they have the concern for the hearing, we need to go for the second line, that is your ABR, auditory brainstem response. So this is the right answer here. So first line newborn testing, hearing testing is automated autocaustic emission test. It's not always possible to get clear response from the first test. This happens with lots of babies and does not always mean baby has permanent hearing loss. So when we need to go for the, and in that case, we can go for the second line testing. And whenever we have to go for the second line, that is going to be your automated auditory brain stem response test. But it is within less than 6 months of the age. Chest X-ray of a 7 days newborn who had an unremarkable antenatal history presented with the progressive shortness of the breath. On examination, heart rate is 166, respiratory rate is 60, subcostal recession, tracheal tug, oxygen saturation was 91%. What is the diagnosis? Congenital lobar emphysema of left upper lobe, right lung collapse or consolidation, congenital cystic adenomatous malformation, hypoplastic right lung, or left lobar pneumonia. This is again very visible. This is your basically left upper lobe congenital emphysema, which is showing you distension, and it is causing the shift of mediastinum to the opposite side. So the right option here is option A, congenital lobar emphysema of the left upper lobe. This has been repeated many times. Patient presented with the high fever and decreased breath sounds on the right side of the chest. Antibiotics was given. What is the best next action to be done? Ultrasound guided small bore drain insertion, large bone drain insertion, CT chest, or the needle aspiration. So this was a case of pneumonia. Antibiotics started, but the patient still has the fever and decreased breath sounds on the right side. So this is a case of your pleural right-sided pleural effusion. So they have started the antibiotics. Now what else do we do? Now next thing is that we have to drain it, and we have to go for the chest drain insertion, but we will go with the ultrasound guided, always option A, and the small bore insertion is always recommended one. Large bone drain insertion is recommended in the adults. So right option here is option A, ultrasound guided small bore drain insertion. So you can see that we have the different sizes. Usually less than like 20 is going to be the small size. So, and in the newborn, we have the different size infant and the child. But they have, this is from the guideline, as you can see that here. March 2025. Or small bore drains should be used whenever possible to minimize the patient discomfort. So one thing is that it is easy to pass. Second thing is that it does not cause the patient much discomfort, and they're always the first line to go, especially in the pediatric population, until there is failure or something else. So in children, we always use the small bore drain insertion, and with the ultrasound guided, we have to go for that. So option A is going to be right one here. 13 years old boy came to the emergency department with acute severe asthma. He has been actively managed with salbutamol and the ipratropium nebulizers, IV hydrocortisone, IV salbutamol, and he has improved initially with good air entry, but after a while, he developed wheezy chest and tachypnea again. Investigation showed metabolic acidosis, high lactate, and the hypokalemia. What is the best action to do? Chest X-ray, add aminophylline, Pulmicort nebulizer, taper and wean off salbutamol, admit on the mechanical ventilation. So you see, the patient was already taking the salbutamol in nebulized form, and we also started the IV salbutamol. As a result, the patient improved, but again, he developed the VZ-test-tachypnea, and there is metabolic acidosis, high lactate, and the hypokalemia. These are all side effects of your salbutamol. And when they are present all together with hypokalemia, with metabolic acidosis, high lactate, then we lead it as the salbutamol toxicity. So right option here will be we have to taper and wean off the salbutamol. So option D is the right one here. So as you see hypokalemia, hyperglycemia, lactic and metabolic acidosis, they are all side effects. And when all these are deranged, then we label it as the salbutamol toxicity. So that's why it is telling you that because of nebulized as well as your IV salbutamol, patient develop all these symptoms. And that's why we need to go with the tapering and the weaning of the salbutamol. Scenario about the child with persistent and the recurrent respiratory symptoms. When do the chest CT described a part of the left lower lung is dysplastic tissue which received anomalous systemic vascular supply. What is the diagnosis? So when you get dysplastic lung tissue with anomalous system vascular supply, that is a case of your pulmonary sequestration. So option B is the right one. None of other bronchogenic cyst, bronchiectasis, or other one have this dysplastic tissue with anomalous pulmonary vascular supply. This is only happens in the pulmonary sequestration. So option B is the right one here. So pulmonary basically sequestration, it is a rare birth condition in which the patient has the dysplastic lung tissue in the form of a mass and which does not function normally and also have the abnormal blood supply which in which a systemic arterial blood vessel coming from the aorta feeds this lung mass of the dysplastic tissue, and it can occur, it can form outside like extralobar or inside intralobar in the lungs, but it is not connected directly to the airways. And the symptoms of this pulmonary sequestration can vary and depend upon the size of this dysplastic mass which is having the abnormal blood supply. And at birth, children present with the wheezing or shortness of the breath, frequent lung infections like pneumonias, repeated upper respiratory tract infections that take longer than usual to resolve, and the feeding difficulties with failure to thrive. And the management is going to be the surgery, the resection of this dysplastic tissue in the form of the mass. So that is whenever a dysplastic lung tissue is present with a anomalous arterial supply, that is going to be your pulmonary sequestration. 8-month-old child diagnosed as the bronchiolitis when need to admit. Respiratory rate above 60, temperature above 38, decrease feeding up till 40, or O2 saturations less than 92%. So if we look about in the guidelines, the criteria for admission, it is SpO2 less than 90% for age children above 6 weeks and SpO2 less than 90 for children who are less than 6 weeks, and inadequate feeding that is less than 75% of normal. Similarly here, the same thing, an inadequate fluid oral intake 50% to 70% of the usual volume, taking account of the other risk factors. So I don't know, they have written is as 40% decrease or patient is only taking the 40%, but still if the oxygen saturation is going to be less than 92%, that is an absolute criteria, and that is more important as compared to the decreased feeding. So maybe in the exam and complete scenarios there, then more options will be more clear. But the most important single thing that you need to consider in the bronchiolitis for the admission is that when the oxygen saturation is going beyond the 92%. So that is more important as compared to your decreased oral intake. So option D, I will take it as the right option here. So this is going to be your right option. Scenario about the baby came to ER with high-grade fever, tachypneic, and the stridor with drooling during intubation. There is inflamed epiglottis and the yellow exudated throat. What is the organism? So as you say that, you can see that there is high-grade fever, tachypnea, inspiratory stridor with drooling and inflamed epiglottis. That is a case of your acute epiglottitis. So what is the organism that cause acute epiglottitis? That is your H. influenza. So option A is going to be the right one here. H influenza because it is a case of acute epiglottitis. And this is, you can see the difference between all of them. And in the acute epiglottitis, it is going to cause by the H influenza. And there will be acute inflammation of the glottis. In the bacterial tracheitis, there will be no inflammation of the acute epiglottitis. There will be only like a pussy discharge will be there in the trachea. This is again the same thing which we have already talked about in the our respiratory sessions also. This is for your revision. I have added the slides also there. Here. Okay, 8 years old child has profound hearing loss. Mother has concerns that he has decreased vision, especially at night, worsened balance. What is the diagnosis? Usher syndrome, congenital rubella syndrome, cerebellar space occupying lesion, or error of refraction. So error of refraction will only cause decreased vision, but it will be cause general, like day and night will be there, but it is not associated with the hearing loss. So this is not a case. Cerebellar, this space occupying lesion can cause the worsening of the balance, but it has nothing to do with or maybe it has nothing to do with decreased vision or hearing loss. Congenital rubella, it will be in this patient will be developmentally delayed, microcephaly, heart defects, and all the other things which has not been given here. The patient is only otherwise well, just have the hearing loss and now worsen balance due to decreased vision at night. So this is a case of your Usher syndrome. Now, what is Usher syndrome? Usher syndrome is basically a rare autosomal recessive genetic condition which affect the cochlea as well as the retina. So if it affect the cochlea, so there will be hearing loss at birth, loss of startling, absence of babbling, and unresponsiveness to the voices will be there. And in the children, then they will present with the delayed speech development, behavioral changes, and in the adolescents with the hearing impairment. And the self-reported vision problem, there will be blurred vision, sensitivity to light, clumsiness, patient will be bumping into the objects because of the decreased vision, especially at night, and balance issues, dizziness, vertigo, and the frequent falls. So it affects the retina and it affects the cochlea, and that result into this your Usher syndrome. So right option here will be option A. 7 years old child with the pulmonary function test in which FE1 is 1.15 and its normal range is this 1.15 to 1.6. So this is normal. FE1 seems to be normal. Yes. And your FVC is 1.55, normal range is 1.40 to 1.8. This is again normal. And your peak expiratory flow rate is 165, which is decreased here because normal is 190 to 220. And residual volume is 0.65, which is normal is 0.35 to 0.60, so it is decreased. So your residual volume has been increased and total lung capacity is 2.20. It is also normal. So what is the cause of increased residual volume? It is air trapping, mucus plugging, equipment failure, or poor inspiratory effort. So poor inspiratory effort will affect all of these things, like total lung capacity, FE1, FEC. It does not just separately affect the residual volume. Equipment failure will also affect all of these. Mucus plugging will affect is also going to cause a single like affect a segmental branch or segment of the loop. It does not affect generalized residual volume. Only option left is the air trapping. So it and that is true because in asthma, what happens? Your lung compliance is decreased. Sorry, lung compliance is increased. It can accommodate an increased amount of the air, but or the elasticity is decreased due to which the your patient this one cannot go the air cannot go out. So that is going to cause the increase in the residual volume. And what is the diagnosis? Let's just say here. So you see in this case, FE1 is usually decreased in asthma and FVC is also somehow, it can be normal, it can be decreased. Obstruction of the airway that result in the decreased emptying of the lungs because of the decreased elasticity. So air becomes trapped inside of the lung. That's why it's an obstructive airway disease. And due to air trapping, your residual volume become increased and your total lung capacity also become increased. So this is a case of your air trapping in which, and it can be mild because FE1, FVC and the total lung, your capacity is normal. And they have just given this RV volume is increased and they have asked about what is the cause of increased residual volume. So that is, it happens after air trapping. So right option will be air trapping. And the most common cause of the air trapping is going to be our bronchial asthma. So option A is going to be this. And these one cause restrictive airway disease. Cystic fibrosis is also the obstructive, but it does not result in the air trapping like that happening in the bronchial asthma. So the right option here will be option A, that is the bronchial asthma. AKP May 2024. 22 months old boy passing the neonatal audiological assessment, and now his mother is concerned about impaired hearing. What of the following is indication of the cochlear implant? So only one option is given, that bilateral sensorineural hearing loss more than 90 decibel. So cochlear implant, one thing is that it is only used in the sensorineural hearing deafness. It is not used in the conductive, because in the conductive deafness there is the defect of the external ear, while in sensorineural there is a defect of the auditory cells and the cochlea and the nerve endings and the other things. So it is only effective in the sensorineural hearing loss. So we use it in the when we have the bilateral sensorineural hearing loss, and that is the profound loss, that is more than 90 decibels. So we usually have the three types of the hearing: conductive, sensory neural, and the mixed. And the degree of hearing loss is that normal is less than 20, mild is 26 decibel to 40, moderate is 41 to 70, and severe is 71 to 90. And when you have the profound, it's more than 90. So cochlear implant is used in severe to profound sensory neural hearing deafness who do not receive adequate benefit from using the acoustic hearing aids. And for hearing aids are usually used for both sensory as well as the conductive, but it is specifically we use it for the conductive hearing loss usually, because the cochlear implants we do not use it for the conductive hearing loss. So AKP January 20, all the other ones were repeated, I think. AKP January 2024. 12-year-old boy presented with the cough and the breathing difficulty, and it is pneumothorax, pneumomediastinum, wide mediastinum, lingual consolidation, foreign body, pulmonary edema, or congenital cyst. No congenital cyst I can see in here, no pulmonary edema, no foreign body, there is no hyperinflation on any side, there is no lingual consolidation, there is no wide mediastinum, and there is also no pneumothorax. There can be only slight air I can see in this area. So it can be a case of pneumomediastinum, even though this is not a typical picture for or the X-ray for the pneumomediastinum. So option B is most likely to be right one, and it is also given in the past records as a right answer. Only in this area I can see the mild like air that is present. So right option here is mediastinum, pneumomediastinum. And what is pneumomediastinum? There is going to be small amount of the gas which appear as the linear or the curvilinear lucences outlining the mediastinal contour. So all the mediastinal structures can have this. So it can result into this like subcutaneous emphysema, as you can see the air in the subcutaneous which gas is accumulated in the neck or the chest wall soft tissues. Then the pneumopericardium can be there, in which you have a thin line of the air which is surrounding the pericardium. So gas anterior to the pericardium like that. And the continuous diaphragm sign, like you can see here, diaphragm is in continuity. That is because of the gas trap posterior to the pericardium, making the diaphragm visible continuously across the midline. And there will be sudden onset of the symptoms like cough and the breathlessness. And we don't need to do anything until unless it's your pneumopericardium, then we have to go for this pericardiocentesis. Otherwise, for the subcutaneous emphysema, we just have to observe it and it resolve on its own self, and we just have to provide the respiratory support. So this is how the pneumodistinum present. And in this case, if it's sudden onset of cough and breathing difficulty, I cannot see any of other features of pneumodistinum or any other option that has been given. Only here small area of the amount is there. So it most likely can be the pneumomediastinum. Option B is right here. Then we have the next scenario, Romanian. 2 years old, cough for the 3 weeks on bronchodilators, not responding. Father is smoker. Mother is asthmatic. Weight is 0.4 centile. Height in 4th, 9th centile. Chest X-ray shows hyperinflation and the peribronchial shadowing. What to do? Sweat chloride, sweat test, nitric oxide, nasal brushing, IgE or the RAST, Monto test or therapy for the father to stop the smoking. So cough for 3 weeks, it's not responding to the bronchodilators with failure to thrive, with X-ray has hyperinflation and peribronchial thickening. Peribronchial thickening with is most uh, your diagnostic for your bronchiectasis, and that's most commonly present with the your cystic fibrosis, or it can also happen in the PCD. So these monotherapy for these will not be true, and the nasal brushing and the nitric oxide we use in the your this primary ciliary dyskinesia, which usually patients present with the nasal polyps, recurrent otitis media, recurrent sinusitis, and then recurrent chest infections. And for the cystic fibrosis, they usually present with the recurrent chest infections and the malabsorptive stools. So there we most likely it is a case of cystic fibrosis, because for the PCD, primary ciliary dyskinesia, more prominent will be the nasal polyps, halitosis, and the recurrent sinusitis. These will be the more prominent features. So, and we cannot nasal brushing, nitric oxide, both are used for the your this primary ciliary dyskinesia. Nasal nitric oxide is screening test, and then nasal brushing is done. So this is going to be most likely, I think this is scenario is going towards the cystic fibrosis with peribronchial shadowing, which happens initially or like at 2 to 3 years. Even the patient can develop that with who are cystic, no, having the cystic fibrosis. So I think most likely, right option will be option A, sweat testing for the cystic fibrosis to rule out that. So I will go here with the option A, and this was the also right option in your past papers, and maybe the or many other things will be there in the scenario which will be pointing more towards the cystic fibrosis as compared to PCD. And among PCD, we also don't know what they're asking, whether for the screening test or the definitive test. So I think this was a scenario of cystic fibrosis. So we will go with the option A, sweat testing. Full-term history of the polyhydramnios after birth, grunting and on mechanical ventilator, congenital cystic adenomatous malformation, diaphragmatic hernia, or congenital lobar emphysema. This is, I can see a cyst here, and I can see a cyst here. This is most likely, I think, a case of cystic adenomatous malformation. It's not diaphragmatic hernia, and there is shifting of the mediastinum towards the opposite side. And I cannot see any over distension of any lobe of of the lung. So most likely, even though this picture is not that much clear and also not that much typical, but I think the most likely option here, depending upon whatever in the picture we can get, this is a case of our congenital cystic adenomatous malformation, option A. Like here, you can see cysts are specifically present like that. And this is also the most common lobe for the cystic adenomatous malformation. This is again the theory I have given. You can go through with that just for your revision. Cystic adenomatous malformation consists of hematomatous or dysplastic lung tissue which is mixed with the normal lung, and it is confined to one lobe. And the other features, then you can see just for your revision. Okay, 12 years old boy had a road traffic accident, presented groaning, severely distressed with tachypnea, respiratory rate of 40, and oxygen saturation was 80, a pulse rate of 140, BP of 160 by 65. Paramedics insert the intravenous line at antecubital fossa. On examination, there is decreased air entry in the left side with the resonant percussion bilaterally, and the saturation decline to 75. What is the next immediate step? Two steps needed. Insert another large bore cannula, bag and mask ventilation, endotracheal tube insertion and the ventilation. Insert left-sided drain or needle aspiration of the left side. So we can see that there is decreased air entry in the left side with resonant percussion. So that is most likely a case of pneumothorax, and that's why the patient saturation also deteriorated. So you see that there is the blood pressure is going to be usually it's normal, so we don't need any other large bore cannula because it has already been passed by the paramedics. So circulation is not that much compromised. Mainly compromise of the respiratory system is there due to pneumothorax, leading to the this decline in the saturation with decreased air entry in the left side and with percussion your note. So one thing that is definitely we have to go is that we will do the needle thoracotomy, because the paramedics is there. It's not possible to do immediately with the your this chest insertion, and it seems to be also the tension pneumothorax, because patient has sudden decline in this in your saturation, and there is history of the road traffic accident. So in the road traffic trauma, most likely it is always tension pneumothorax, and the immediate management is that we have to go with the needle aspiration on the left side. And the second step is that we can go with the endotracheal tube insertion and the ventilation. Bag and mask ventilation is avoided in the pneumothorax because it can further cause aggravated. So that's why the option C and the option E is more likely going to be the right option here, because we have to support the respiratory system along with the management of the underlying disease, underlying cause. So for that, we go with the needle aspiration of the left side, and then to support the respiration, we will go with the endotracheal tube insertion and the ventilation. So these two most likely right option here. Then we have the AKP September 2023. Chest X-ray of a child had pneumonia in the right lower lobe 4 weeks ago and treated. Now presented with the cough only. What is the best investigation? Chest tube, chest CT ultrasound, CT chest, ultrasound diaphragm, CT thorax, or urgent referral to surgeon. So you can see that there is the basically this is the pleural effusion on the right lower lobe with blunting of your cardiophrenic as well as the costophrenic angle. So this is most likely a case of pleural effusion as compared to consolidation, because in that the heart border remains intact in and even though there is blunting of hemi diaphragm, if it is left lower lobe, and in consolidations, it is not consolidation simply as homogeneous opacity with blunting of both your costophrenic and cardiophrenic angle. So for that, we need to go with the ultrasound of the chest. I think this is the most likely option. They want to write it ultrasound chest, but they write it as ultrasound diaphragm. We don't go for ultrasound diaphragm. So option C is the right one here, ultrasound chest. This is again the same scenario which we discussed. 12 years old boy, road traffic accident, and there is saturation drop, decrease air entry. Now they have asked about what is immediate step. In that scenario, previously they asked 2 steps, so we will go with that. But now they have asked about what is the immediate next step. So we will go with the immediate next step is that we have to resolve this pneumothorax. And for that, we will go with the option E, that is the needle aspiration of the left side. That is the most important and most immediate step which we need to do, and after that we can see whether there is improvement or not, and then accordingly we can go with the endotracheal tube insertion and ventilation. So only the most important and the most immediate step, one step if they ask, then you have to go with the option E, needle aspiration of the left side. Then we have the 12 years old boy 12 years old boy. He came back from the Pakistan and staying with the relatives for the last 6 months, and had BCT vaccine when he was a baby. He came with the breathlessness during playing football in the school. He received salbutamol nebulizer with no marked difference. What is the X-ray showing you? Right hilar lymphadenopathy, cardiomegaly, right aortic notch, right lower lobe pneumonia, right middle lobe pneumonia. So this is most likely your only hilar lymphadenopathy, because your right heart border is intact. So it is not your right middle lobe. It is not your right middle lobe pneumonia in which your right heart border is obscured, and your right hemidiaphragm is also intact. So it is also not right lower lobe pneumonia in which your hemidiaphragm is going to be obscured. No right aortic arch has been given here. No cardiomegaly as it is of the normal size here. Only option that is left here at is indicating this is the right hilar lymphadenopathy, as it is a most likely a case of your TB. So right option here is going to be your option A, right hilar lymphadenopathy. 12 years old, referred to outpatient clinic with expectorant cough. This is again the same scenario has been repeated. Clear sputum, received 2 short courses of amoxicillin, not improved. On examination, height and weight on 50th centile. Patient is afebrile, pink with no focal sign, not the same pig. This is totally normal X-ray they have given here. There is no finding in that except the extra exposure has been done. And the answer was superior mediastinal mass, as we discussed also in the previous recall, in which they have marked it as the right one here. So the option A is the superior mediastinal. Okay, here is the right lobe pneumonia, I think, maybe. Previously, it was given as the, in the previous scenarios which we discussed, they marked it as a superior mediastinal mass, and they mention it that there was the wide mediastinum or mediastinal mass was present there. But here they have given the right middle lobe, I think, pneumonia, but we don't have any features of right middle lobe pneumonia here, because there is right heart border is totally normal. It should be obscured in the right middle pneumonia, and we cannot see any opacity here. So just on the basis of whatever they have given you, maybe it's right middle of pneumonia in your exam scenario, in your exam X-ray picture. Because obviously on the basis of this scenario, it's pneumonia. But what pneumonia, right middle, right lower, left middle, left lower, or the upper, we don't know. So until unless we have the exact X-ray, this is normal X-ray totally. So in the previous recalls, the answer was given as the right middle lobe pneumonia. 12-year-old girl presents with the cough and shortness of the breath, received 2 courses of amoxicillin with no improvement. On examination, weight and height was 50th centile, pink vent cough, no focal lesion. On auscultation X-ray was done. What is the finding on this X-ray? Lingual consolidation, right middle lobe consolidation, bronchial wall thickening, or hilar lymphadenopathy. It's not right middle lobe because your heart border is intact. Now this is your lingual consolidation. As you can see, your left heart border is obscured here, and this is in the presence, or you can say in the area of your this lingula. You have this consolidation, you have this patchy infiltrates with normal your right hemidiaphragm, so it's not your right lower lobe. So the as lingula is the lower part of your upper left upper lobe, and when it gets consolidation, there is obscuration of your left heart border that is there. So the right option here will be option A, it's lingular consolidation. So you see, this is the same picture they have given in the exam. Lingular consolidation, homogeneous opacity over the left heart border, obscuring it, as lingula lies adjacent to the left heart border. So you can see the left heart border here is basically obscured, and there is the homogeneous opacity is present there. Opacity may extend from the hilum to the cardiac border, and normal left hemidiaphragm and costophrenic angle will be there. So you see, you have the normal left hemidiaphragm, normal costophrenic angle, so it differentiated from the left lower lobe consolidation. 12-year-old boy playing football came with the sudden onset of the cough and shortness of the breathing. What is the finding in the chest X-ray? Right hyperinflation, right pneumothorax, right fluid infiltration, left lower lobe collapse, hilar lymphadenopathy. So if we see this case, there is right-sided hyperinflation with hyper, you can say the lucency. Also, your right hemidiaphragm is depressed, elevated. So this is going to be your a case of right pneumothorax, as the history of the trauma is there. Patient was playing football and then sudden onset of the cough and shortness of the breath. There is no hilar lymphadenopathy, there is no left lower collapse, there is no fluid infiltration. Yeah, hyperinflation is there, but more likely it's your right pneumothorax, because there is basically, you can see, there is totally loss of the pulmonary vascular markings here. In just hyperinflation, all the like this. You see, all the bronchopulmonary vasculation will be visible here. But in the pneumothorax, it will not be visible, and it is most likely pneumothorax because it is totally lost in this part of the lung. So the right option here will be option B, right pneumothorax. And you can see in the pneumothorax, you get hyperlucent lungs like here, and the mediastinal shift to the opposite side, especially if it is the tension pneumothorax, and the absent bronchovascular markings. As you can see, you cannot see any bronchovascular markings here. Chest X-ray of a teenager boy with no recent history of the trauma, not on any specific medications, came with the chest pain within 6 hours. What is the diagnosis? Pneumomediastinum, pulmonary edema, foreign body, pneumothorax, or congenital lung cyst. We cannot see any congenital cyst in this X-ray. It's not pneumothorax. There is no hyperinflation or hyperlucency. So that's why it's also not the foreign body. And the pulmonary edema, it is also not there because your heart is going to be the normal here, of the normal size. It should be enlarged in the pulmonary edema with failure, and also not that much fluffy infiltrates there. It is a case of pneumomediastinum. As you can see, it's approximately becoming a continuous diaphragm sign, and as well as you see all this area is having this air in the your soft tissue and the neck area. So this is most likely, and in this area the air is also present. So all the air is going to accumulate in the mediastinal, around the mediastinal structure. So this is most likely a case of your pneumomediastinum. Option A is right here. A 1 week old infant with persistent chest symptoms since birth. What does this X-ray show? Left-sided congenital lobar emphysema, left pneumothorax, left pulmonary interstitial emphysema. So it's again, you can see this is your going to be the distension of your left upper lobe causing the mediastinal shift towards the opposite side. So this is a case of your left-sided congenital lobar emphysema. So option A is right here. AKP May 2023. 12 years old child presented with a 6 hours history of sudden onset of the chest pain, shortness of the breath, and he was anxious. Pulse rate is 130 on examination, respiratory rate is 40, temperature is 37.6, saturation is 93% on the room air. Put on oxygen, clear chest examination, picture of the pneumomediastinum was there. What is the most appropriate next action? Observe and monitor symptoms, no treatment, admit pericardiocentesis, thoracocentesis, IV ceftriaxone, azithromycin, salbutamol nebulizer, IV hydrocortisone. In your pneumomediastinum, we just have to do with the symptomatic management. And so that's why these IV ceftriaxone, salbutamol of no use in this pneumomediastinum. Thoracocentesis and pericardiocentesis is done when there is pneumopericardium and there is pneumothorax along with that. So we don't need to do that. No treatment is also not. The main thing is that when the patient is already on oxygen, patient saturation is normal, patient temperature, respiratory rate is normal, then we don't need to do anything else. We will just observe and monitor the symptoms, and if they get worse, then we will provide them the further respiratory support. If they develop the pneumopericardium, then we can go with the pericardiocentesis and all these things. And if the patient is on oxygen, it means patient has already been admitted. So this is also not the right option here. So, and only air, we can see this part, air is present in this part. And this is also you can see a continuous diaphragm sign is here. So this is the right option here will be that we have done all those things. Patient is vitally stable, already on the oxygenation. Because of the shortness of the breath, we have given the oxygen, and respiratory rate is normal now and slightly increased. And also the saturation is normal. So the only thing that we can do was the oxygen, and now we will just observe and monitor the symptoms. And if they deteriorate, then we have to provide the further support. So option 1 is going to be the right one here. Chest X-ray 7 days baby who had unremarkable antenatal history presented with progressive shortness of the breath. On examination, heart rate is 166, respiratory rate is 60, subcostal recession, tracheal tug, oxygen saturation 91%. What is the diagnosis? So this is again, you can see left-sided congenital lobar emphysema. So right option here will be your congenital lobar emphysema of the left upper lobe. 6 years old ventilated for pneumonia. Ventilator settings were given as follows. PCO2 is 14, which is quite high because normal is up till 6. And PO2 is 20, which is also high. And the PIP is 26, PEEP is 6, TI is 0.8, but ventilatory setting to change. So you see both your PCO2 and PO2 are going in the same direction. So you will change the PEEP. And as they are increasing, so we will decrease the PEEP. So we will decrease the PEEP. We have to go opposite of them. So this will be the decrease the PEEP will be the right option here, option 1. This one. So you see both PO2 and PCO2 are going in the same direction. So we will change the PEEP. And how we will change the PEEP? If they are increasing, we have to decrease the PEEP. So the right option here will be decrease the PEEP. AKP January 2023. Patient had 4 days history of the epigastric pain, vomiting, a fever, 38.9 degree, took paracetamol and brufen, not improved, asked for the chest X-ray finding. Right upper lobe consolidation, right middle lobe consolidation, right perihilar shadow, right left lobe consolidation, right upper lobe collapse. So as you can see, the right up border is almost intact here, but the right upper mediastinal contour is lost here. So this most likely is going to be your right upper lobe consolidation, even though this is not a typical, I can say, X-ray, but still most likely it is going towards the right upper lobe because your right hemidiaphragm is intact. So that's why it can't be right lower lobe consolidation. Your right heart border is intact, so it's also cannot be right middle lobe consolidation. Most likely it's going to be your right upper lobe consolidation. Option A is going to be the, yeah, this is the right one, because in the right upper lobe there is homogeneous opacity in the right upper lobe, lower margin sharply defined by the horizontal fissure. So I can say that fissure has been here, has been like, you can see it here because of the this all the homogeneous opacity that has make it depressed there. So, and the loss of the right upper mediastinal border, like you can see here, you cannot appreciate the right upper mediastinal border, and the normal and the distinct right heart border will be there like that here. So we have normal and the distinct right hemidiaphragm contour is also there, and the air bronchograms are there, and no or minimal volume loss or the mediastinal shift until unless associated with the collapse. So most likely it's right upper lobe consolidation. The patient was given cefuroxime for 5 days, but this his condition didn't improve. What is the best next investigation? Near to this effusion was more prominent. So as this is not the typical picture, they said that there was the effusion in the chest X-ray after this pneumonia, which is not improving. So for the pneumonia effusion, the next investigation we always go for that is the thoracic ultrasound. So the option B is going to be the right one. This is not the actual X-ray which they have. They said that the fusion was there. So that's why we will go with the thoracic ultrasound. AKP September 2022. So the child had a history of 2 previous attacks of the chest infection. He was first diagnosed as having asthma but didn't improve with asthma medication, and now he presented with the fever, cough, and tachypnea. Sputum culture showed pseudomonas. What does this X-ray show? Right-sided hyperinflation? No, this is not. The left lower lobe consolidation? Yes, it can be. Right-sided pneumothorax? No. Or left-sided pleural effusion. Now this X-ray is not typical for it. Both two possibilities can be there, either left lower lobe consolidation or either it is left sided pleural effusion. Pleural effusion, as there is obscuring or blunting of cardiophrenic and costophrenic angle is there, and this is the meniscus sign is also here. So most likely it is a case of left sided pleural effusion. Left lobe consolidation, if it is there, then the left heart border should be intact there, which is not which is not, look, we can see here. But in the previous year exam, they have marked the answer as the left lower lobe consolidation. So, but if we see the X-ray, then it is going to be your left-sided pleural effusion. And as it is pneumonia and it is pseudomonas, so both possibilities can be there. It can be pleural effusion, it can be just lower lobe consolidation. So, depending upon the X-ray in the exam, you will opt for the right option, whether it's your lower lobe consolidation or it's left-sided pleural effusion. Because according to this X-ray, which they have taken it from the internet, the right option is most likely left-sided pleural effusion as compared to left lobe consolidation. So always correlate that whatever the instead of rectification, just see that which this X-ray, how interpret the X-ray, that whether it's your FIAN, whether it's your consolidation, it's middle or the lower or whatever it is, and then mark the right option here there. So you see that in the left lobe consolidation, we already talked about the left heart border is visible, loss of only left hemidiaphragm contour, and there is homogeneous opacity. Picture: newborn started to fed well and passed meconium, then developed respiratory difficulty. And in the exam, very bad picture. Okay, so this is a picture of your congenital diaphragmatic hernia. As you can see, all the bowel loops are present in your left-sided chest cavity, and they have caused the mediastinal shift towards the opposite side. As these are all bowel loops, you can see that. So the option 1 is right, congenital diaphragmatic hernia. AKP May 2022, indications for cochlear implant: bilateral sensorineural hearing deafness above 90 decibel, or conducting deafness, unilateral sensorineural, unilateral congenital conducting of 70. There is only one indication, that is bilateral sensorineural hearing deafness of profound, that is above 90 decibel, and especially along with if they have used the hearing aids and it had not benefited them, then you will go for that. We do not use it for the conductive hearing deafness. So right option will be bilateral sensorineural hearing deafness of above 90 decibel. Again, this is the same thing which we talked about. Whenever there is profound deafness, bilateral sensory neural, and they do not receive adequate benefit from the acoustic hearing aids, then we go for the cochlear implants. And for hearing aid, for your conducting hearing loss, we do not go for the cochlear implants. This is the difference between your conductive and the cochlear deafness. The site of Leon in conductive is the outer or the middle ear, while in the sensory neural deafness, it is inner ear, cochlear or auditory nerve. In conductive, it is impaired sound conduction in the inner ear, while there is damage to the hair cells or the auditory nerve in the sensory neural deafness. Common causes is the wax, otitis media, tympanic membrane perforation, or otosclerosis in conductive deafness, while it is presbycusis, noise exposure, ototoxic drugs, or the viral infection leads to sensory neural. Severity is that the conducting is usually mild to moderate. It rarely goes above profound or severe, while the cochlear usually it goes above profound hearing deafness, that is above 90 decibel. Then sound quality is muffled but clear when loud in conducting, while in the sensory neural it is distorted even when the frequency is loud. Air conduction is reduced in the conducting deafness with normal bone conduction, while in the sensory neural, both air conduction and the bone conduction is reduced. And the Rini test is positive, in which air conduction is more reduced as compared to bilateral, and the same thing. We usually do not perform these nowadays, and the treatment is medical or surgical correction in conducting deafness, hearing aids, and the other these amplification test. And it is often reversible, the conducting one. But sensory neural, we use the hearing aids. If they do not respond to that, then cochlear implant if it is severe, and it is usually permanent. So you see, we use the cochlear implant in the sensory neural severe or profound hearing deafness, but in conducting, we usually just go with the medical treatment, surgical correction, or the hearing aids, or the amplification of the hearing. Then we have the chest X-ray, 18 months old, which came with the coryzal symptoms, bilateral respiratory wheeze, and asked for the X-ray findings. Whether it's posterior rib fracture, it's your rickettsial rosary, it is wide mediastinum, hyperinflation, or absent thymus. So you can see that there is a fracture of the rib here. That is your posterior rib fracture. This one, because these are your anterior ribs. These one, this is your posterior rib. This one, and this is also the fracture here. So these two ribs are basically, there is the posterior rib fracture, and this is a case of your child abuse. Rickettsial rosary, I cannot see anything, and it is rickettsial rosary you see on the physical examination. Here we cannot see any osteopenia. Wide mediastinum is not there. It is only 18 months old. No hyperinflation, no absent thymus. So this is a case of your this. You can see this is your posterior rib fracture. So option A is going to be there. AKP January 2022. Cystic fibrosis patient shocked, having vomiting, received boluses, sodium 135, potassium 2.6, received potassium replacement and IV fluids after 3 days, presented with the following labs: sodium 133, potassium 2.9 management, give potassium sodium orally, give potassium supplements, and give fludrocortisone. So this is a case of hyponatremia with hypokalemia and secondary to the vomiting. In the patient of cystic fibrosis, this is a case of your pseudo-Bartter syndrome, in which because of this persisting vomiting and the loss of the chloride also from the sweat and due to vomiting, and the electrolyte disturbance is going to be there, leading to hyponatremia, hypokalemia, even metabolic alkalosis. So that is called as a cystic fibrosis because it happens in a patient of the cystic fibrosis. So underlying cause is already there. So in that case, we only need to replace the supplements, that is sodium and potassium we will replace orally, because now the patient has been stabilized and has been discharged, and after 3 days he is having this electrolyte abnormalities. So this we will go with the sodium potassium orally. Pseudo-Bartter syndrome secondary to cystic fibrosis can lead to hypokalemia, hyponatremia, and metabolic alkalosis. AKP September 2021. X-ray chest asking about the findings to answer, and there was different photo than that. Lingual consolidation, right middle lobe consolidation, right upper lobe consolidation, right hilar consolidation, lymphadenopathy. This seems to be right upper lobe consolidation, and this seems to be like right lingual, I think, consolidation, because this is not the same picture. So in that case, the right answer in the previous records was lingual consolidation and the right middle lobe consolidation. In the right middle lobe, this border should be obscure, but it is not. So this is not the actual picture. Don't waste your time on that. You know what happens in lingual consolidation, you know what happens in right upper middle lobe consolidation. Just from the x-ray, see what is the x-ray is featuring what consolidation, whether it's upper lower lobe or lingual, and then just go along with that. This is the answer which they have given in the previous recalls, which was actually present in the paper with actual chest x-ray. Infant with the brief febrile, acute febrile illness and the cuff, his chest x-ray is shown. What is the next step? CT chest, ultrasound chest, or no investigations or urinary catecholamines. This seems to be, I don't know what shadow is there, but otherwise this x-ray is totally uh, unremarkable. We don't need to go for the chest x-ray here. Sorry, CT x-ray or ultrasound x-ray, no indication there, no indication of urinary catecholamines. So I think it's just brief acute febrile illness and cough, so we don't need to do anything. So no investigation we need here. I think that because it seems to be normal x-ray. So no investigation we needed. Okay, a 12 weeks old baby was found by his parents blue and apparently lifeless in his cot after they had heard him choking. His father revived him with mouth to mouth resuscitation and brought him to the hospital. He was born at 36 weeks gestation, weighing 22.4 kg. He had no perinatal problems and fed well by bottle, although he frequently regurgitated his feeds. His parents reported that he had been unwell with a cough for a few days before admission, and his two siblings, aged 5 and 3 years, had both been unwell recently with chest infections. So there is a history of viral infection in the siblings, and patient is also unwell for 2 days, and now he had apneic episode for which he was revived. So father had been unemployed for 18 months, and there were considerable financial problems. On examination, he was pale and has a nasal discharge. His weight was on 10 centile, slight intercostal recessions, and respiratory rate of 40 minutes were noted together with the scattered fine crepitations and high pitch expiratory wheeze is there. Okay, this is most likely a case of your bronchiolitis. Remainder of the examination was normal. Examination of the urine revealed no protein, no sugar, no cells were seen on microscopy. A chest x-ray showed a degree of overinflation with no localized opacities. So as it is 12 weeks, 3 months old, very common age to get the viral infection, specifically when there is a contact with the siblings who also have some viral infection. And the in the infants or less than 6 months, the patient usually, instead of respiratory distress, they present with the apneic episodes in the bronchiolitis. So this is a most likely, and when you have this high pitch expiratory wheezing and the overinflation, no opacities, that is most likely a case of your viral bronchiolitis. Okay, what is most likely diagnosis? Congenital cardiac abnormality, no clue. Cystic fibrosis, no clue. GERD, no, he spit it, but the weight is okay and he does not have that. Milk aspiration, there should be, it is not associated with the cough, with the patient has been unwell and with also exposure to the other sibling. Pneumonitis pertussis infection, this is not like that. There should be, and in that there is no wheezing in the pertussis infection. So most likely it is a case of your viral bronchiolitis. Yes, this is viral bronchiolitis. And this is the same scenario. Infant was found breathless in cot few days ago, had nasal discharge. His father tried to resist it by mouth-to-mouth breathing. Father is unemployed. Two siblings have the common cold. X-ray showed hyperinflation. What to do? So now in that they have asked about diagnosis. In this scenario, they have asked about the investigation, and the bronchiolitis most commonly caused by the RSV, and for that we go with the nasopharyngeal swab. So per nasal swab is basically used. Per nasal swab, we just take the swab from the nostrils. Nasopharyngeal swab we take from the upper part of the nose as well as from the throat, and it is more appropriate and more definitive, and it is done in the you can say the hospitals where the more the reliable the paramedics and the doctors are available, and they know how to take the nasopharyngeal swab. Per nasal swabs are usually taken in the laboratories or at the home in the home service kits. So the right option here when the child is in the hospital, we will, and the definitive is going to be your nasopharyngeal swab. AKP May 2021. This is your extended matching questions. We have the different options and we have the three scenarios. A 3-year-old boy with a 2-week history of the cough. Auscultation revealed wheezes on the right side of the lung. So 2-week cough and only one-sided wheeze in a 3-year-old child. Most likely it is a case of your foreign body, because asymmetric wheezing only happen in foreign body. It does not happen in any of other infection like this bacterial tracheitis, laryngo, while they are all going to cause the bilateral wheeze. When you get only on the right side lung with prolonged cough history, 2-week history in a 3-year-old child, which is more prone to get the foreign body. So this is more likely option D, is foreign body is the right one. A 6-month-old boy presents with the worsening of inspiratory and the expiratory sounds, which started at the age of 3 months. So at the 3 months, this expiratory and inspiratory most likely started, and it is worsening even at the age of 6 months. This is the typical history of your vascular ring. The stridor or the worsening of this sound, they started at the 3 months of the age, and at the 6 months when the solid started, then they become more worsen along with the dysphagia. So the right option is here is the vascular ring. Other one are going to be, they are all infections and they do not persist for 3 months, and the laryngomalacia present at the birth within 1 to 2 weeks. A 2-year-old, so right option will be vascular ring. Next is a 2-year-old boy with a 2 days history of the cough, inspiratory noisy breathing, a runny nose, fever of 38.1 degree, respiratory rate was 60, and there were mild intercostal recessions. So this is most likely a case of your bronchiolitis, because 2 years old cough, and then there is a runny nose and inspiratory noisy breathing. Fever is also 38.1, mild intercostal. No, this is a case of your laryngotracheobronchitis, because inspiratory noisy breathing is there. Yeah, it is a group. When you get the, and in the bronchiolitis, you will get the expiratory wheeze. Here you have the inspiratory noisy breathing, that is inspiratory stridor. So that is more going towards your croup laryngotracheobronchitis as compared to bronchiolitis, in which we get the expiratory wheeze. So the right option here will be option B, that is the laryngotracheobronchitis. So these are the answers: foreign body, vascular ring, and the laryngotracheobronchitis. A 4-year-old child who was ventilated post-operatively. PIP is 18, PEEP is 5, FiO 2.6, hypoxia. On examination, there was equal air entry bilaterally, and the tube was clear. The chest was not rising adequately, but the chest movements improved on the bag mask ventilation. SpO2 90%. pH is 7.2, PCO2 is slightly increased, PO2 is decreased, and the bicarb is 32. What is the next step? So they are going in the opposite directions. So we will change the PIP, and as the PIP is, we change it in the same direction as the PCO2 is going. So we will increase the PIP. So the option B will be the right here. Change ETT, no, because we already have the equal air entry bilaterally, so we don't need to do that. Right option is B. Yes, this is the increase the PIP. 2-year-old girl presents with a cough and fever for 2 days. Then she developed the biphasic stridor and was unable to take anything by the mouth. Her rate was 50 and SpO2 of 93. What is your management action? Select one answer. Humidified O2 only, nebulized budesonide, nebulized adrenaline, IV adrenaline, or nebulized saline. Usually in the croup, this is a scenario of the croup, we only get the inspiratory stridor. When it becomes biphasic, it means it is severe and patient is unable to take anything by mouth. And it is a severe croup And in severe group, we give the adrenaline plus steroids. This has been a controversial question in the past also, that whether we give the budesonide or we give the adrenaline, because both are mentioned. So I have again dig out deeper into that, and the different guidelines which I came across is that the first thing is that you will give them the adrenaline, and after that you can give them the oral steroid. But if the patient is unable to take oral, then you can give nebulized budesonide, but it is not preferable. So the right option here is option C, that is the nebulized adrenaline, because it acts early. Steroid take 30 minutes to have the action. So meanwhile, we need to give the adrenaline, and as it is very severe with biphasic stridor, we have to relieve this obstruction immediately, and for that we go with the nebulized adrenaline. So this is the right option. As you can see in the severe, these are the categories, and this is the management for this severe group. And in that, give high flow oxygen with the help of their parent, and give nebulized adrenaline, and then give oral dexamethasone. And if the child is too well for the oral medication, then give the nebulized budesonide. Then we have another this guideline, in which this is the for your severe group management. Keep the child calm and adrenaline, and this dose can be repeated after 30 minutes, and then oral dexamethasone. And budesonide can be used, but oral dexa is preferred. So you see everywhere the adrenaline is the on the first step, you have to go with that, and then you can give the steroid along with that, because adrenaline takes acts while steroid is taking time to work. So we have to, when biphasic stridor is there, we have to work. Biphasic means inspiratory and expiratory stridor at rest, when it is present in both inspiratory and expiratory component. So that's why most likely the right option here is the nebulized adrenaline. A 5-year-old boy with history of the Haemophilus influenza meningitis at the age of 4 years, which improved on antibiotics. The audiogram was done. Comment on the left side. Okay, what is its mild sensorineural hearing deafness, moderate or severe, or its conducting? Now you can see that for the people who don't know, audiogram is given. On the x-axis, basically, we have the frequency in the hertz from low to high pitch. And on the y-axis, there is decibels, as you can see here. Okay, where this is the frequency on the x-axis from the low pitch to the high pitch, and on the y-axis we have the decibels, and from the quieter to the louder. And basically, hearing is tested in both ears separately. Both ear conduction and bone conduction are tested independently, and the symbols we used for them. For the air conduction, we use X for the left ear and O for the your right side air conduction. While for the bone conduction, for the left side, we use this bracket, and for the right side, we use this bracket, and we make it like that on the graph. And remember that for this is one like here. You can see this is given your air conduction here, and this 0 is basically your right sided, and this X is your left sided air conduction. So on the right side, this one, this is beyond. You can see here it is 100, I think approximately. It is not that much clear. So it is going beyond the more than 90 decibels, because it is around this more than around, because more than it is decreased more than 100. So above 90 decibel, it is going to be your, and also towards the high frequency, it is usually your sensorineural hearing loss, along with your decrease this one your bone conduction is also reduced in case of your sensorineural. Both air conduction and the bone conduction are reduced in your this one sensorineural hearing loss. Yes. So this is the air conduction which is given, which is quite high, and that is more than 90 decibels and with high frequencies. While here you can see, sorry, this is given. No, this is right. Okay. I don't know what they have given, but they asked about comment, because it seems to be the normal one. They asked about comment on the left side. So this is the left side picture, and here we are given both right and the left sided air conduction, which is greatly reduced and of the more higher frequencies. That is telling you this is your sensorineural hearing deafness. And because the bone conduction is not that much severe, it is only keep or remain within moderate limits, and it is also not that much higher frequencies. So this is a case of your severe sensory neural hearing loss. Maybe the more in the exam it will be more clear to you. So these are the audiograms features which you need to know, the symbols when they give you. And this is what we already talked about. When it's more than 90 decibel, it is profound. And in the normal hearing, it remains above 20, between 0 to 20. The your this like air conduction is there like 0 and X for the right and the left. When it is above 20, it remains in between -10 to 20. It is normal hearing. But in the sensory neural hearing loss, both air conduction and bone conduction readings will be more than 20 decibel plotted below the 20 decibel line chart, and this may affect only one side more than the other or both sides. So you see both air and the bone conduction. This is given for the right ear. This is your 0 and the bracket for the right side. And this is your X and the bracket for the left side. So both are, you can see it's below your 20 decibel and it is around 70. It's about moderate to severe, falling into moderate to severe category. And as both are reduced, air and the bone conduction, so this is going to be your sensory neural hearing loss. While in conducting hearing loss, bone conduction readings will be normal between 0 to 20, but air conduction will readings will be greater than 20 decibel. So you see, in the conducting hearing loss, you will get normal bone conduction. So this bone conduction, which is right and left given, it is normal because it is falling above 20 decibel. But your air conduction has been reduced here. So this is your conducting hearing loss. And in mixed hearing loss, both are going to be reduced. Both air and the bone conduction readings will be more than 20 decibel in patients with mixed hearing loss, but difference between them, difference will be more than 15 decibels. So you see that here it is lying your bone conduction, which is below 20 decibels, so it is reduced. There's hearing loss, and this is your air conduction. And among that, it is lying about around 40 to 50, and it is lying about around 80 to 90. So it is becoming approximately 40 decibel difference. So whenever you get, because in the sensorineural deafness, both air and bone conduction is reduced, but their difference will be less than 10 decibel. But, and in mixed hearing also, both are reduced, but their difference, if it is more than 15, then it will tell you that it is mixed hearing loss instead of the sensorineural hearing loss. So this is the same thing. In sensorineural hearing loss, the difference between air and bone conduction is less than 10 decibel. While in the mixed loss, there is the difference between them is greater than 15 decibel. But only if the air conduction is giving on the graph. So like in the first picture we have in the scenario, if they're lying between 40 to for 20 to 40 decibels, then that is your conducting hearing loss. And if it is more than 40 decibel, then it is sensorineural hearing loss, like here. You see here, we only have this one is the air conduction has been given of the right and the left side, and it is more than 40. 40 is around, this is I think 40, yeah, this is the 40. If it lies between 40 to 20 to 40 decibels, then it will be your conducting hearing loss. But if it is lying more than beyond the 40 decibel, then it is your sensorineural hearing deafness. It is the case when only they give you the air conduction on the chart. So when they give you both air conduction and bone conduction, then you have to go along with these charts, that what is the difference between them and what are they. But only if air conduction is given on the graph, then you need to see what is the frequency, what is the level. If it is between to 20 to 40 decibel air conduction, then you will label it as the conducting hearing loss. And if it is more than 40, then it is your sensorineural hearing loss. The next patient is recall is a patient with the annual allergic rhinitis was not responding to oral antihistamine. What is the next step in the management? So after oral antihistamine, next is the nasal spray, and we use the steroid spray. So that's why the right option here will be the option B. Intranasal steroid is the right option after oral antihistamine. We don't use the oral intranasal decongestant or oral prednisolone for the allergic rhinitis. AKP January 2021. The case with the nasal polyps and the recurrent otitis media, and X-ray with the hilar lymphadenopathy and the clubbing. So what is the possibility? As recurrent otitis media, nasal polyps, with hilar lymphadenopathy clubbing, most likely it is a case of primary ciliary dyskinesia. For the cystic fibrosis, there is recurrent chest infections plus malabsorptive stools. And what is the X-ray finding? X-ray finding is that as your right heart border is obscured here with opacity, this is your middle lobe consolidation here. This is your middle lobe consolidation. So primary ciliary dyskinesia and the middle lobe consolidation. So this is again the primary ciliary dyskinesia theory, which we already talked about in the respiratory. I have given it for your just revision here. And this is for the cystic fibrosis. And remember that in primary ciliary dyskinesia, we have almost all the symptoms like recurrent otitis media and the nasal polyps and the sinusitis and the recurrent chest infections. We also get these things in cystic fibrosis. But in PCD, primary ciliary dyskinesia, we don't have the malabsorptive stools, which is a very general and prominent finding in case of cystic fibrosis. This is the picture for the cystic fibrosis. Infant has the biphasic stridor which increase with the supine position with wheezing on auscultation. There is frequent vomiting and the multiple admission in 10 days. What's the investigation? Barium swallow, high resolution CT chest, echo, chest x-ray or laryngo tracheobronchoscopy. This is a most likely case of laryngomalacia because that is typical for the laryngomalacia to increase its stridor with the supine position and with the multiple admissions also and the wheezing. So for that, we go with the laryngotracheobronchoscopy for its diagnosis. So the option E is going to be the right one here. This is the same thing, the theory. You can go through it by yourself. AKP September 2020. Okay, these were all repeated. AKP September 2019. 5 years old boy with history of the fever, cough with shortness of breath received 7 days of amoxicillin but didn't improve. On the X-ray, what is its right upper lobe pneumonia, lymphoma, TB, teratoma, or the thymus? It is none of them. It is most likely as right upper lobe pneumonia because you can see that there is opacity and it has obscured the right superior, this contour like here. So it has been obscured. So this is most likely a case of your right upper lobe pneumonia. And these are the same features which we already discussed. Patient with the fever and the cough and X-ray of the round homogeneous opacity. As you can see in this case, this is your round homogeneous opacity. So this is a case of your right rounded pneumonia, right-sided round pneumonia. So option A is going to be the right one here. And this is the round pneumonia features we discussed in respiratory sessions. This is also again for your revision. Okay, X-ray needs diagnosis. Patient with sudden onset of chest pain, unstable, pneumomediastinum, pulmonary edema, Loeffler syndrome, or miliary TB. As you can see, there is the air all around this heart also, and this is also making a thin linear, curvilinear lucensis. This is most likely a case of your pneumomediastinum, and especially with sudden onset of the chest pain and the unstable. Heart shadow is normal, so that's why it's not pulmonary edema, neither miliary TB. Most likely it is a case of with sudden onset of the chest pain and the distress, that is going to be your pneumomediastinum. Option A is the right one here. AKP May 2019. Teenage non-asthmatic patient came with cough for 1 month. Pneumonia, received treatment but not improved, may have yellowish fruity sputum. Mycoplasma scenario, there is X-ray with no localized consolidation. Exercise intolerance, what is the diagnostic investigation? Mycoplasma serology, CT, bronchoscopy, or lung function test. Now, this is a very poor scenario. Patient is a known case of asthma, have cough for 1 month, and pneumonia, received treatment, no improvement, and exercise intolerance is also there. If we see that asthma, cough for 1 month, not responding to antibiotic, and exercise intolerance is there, that is telling us that it is a case of uncontrolled asthma and we need to go with the lung function test. But then they put it like pneumonia is there, for which we don't have any evidence. Received treatment, but no improved yellowish fruity sputum, mycoplasma serology, and in on X-ray there is no localized consolidation. So I don't know. I think they have mixed two scenarios along with that because no consolidation with and pneumonia is there, yellowish fruity sputum, And mycoplasma scenario, we don't know what is going on here. I was unable to comprehend this scenario. But in the exam, in the previous records, they have write it down as the CT test. We will go with that, which I also do not know why we will go for the CT test here. So I'm really sorry. I don't know what is the answer here because asthma is there, uncontrolled exercise intolerance. Then they add the mycoplasma scenario, which is also not, we cannot see why, because in mycoplasma there should be something on the X-ray also. Even infiltrates, they should be there. So I don't know, but the answer is given CT test, but I'm sorry, I am unable to comprehend this scenario, so I cannot logically explain it why the CT test is going to be the right answer there. Maybe in the exam when you will get the complete scenario, then you will be able to comprehend it. AKP January 2019 repeated, AKP September 2018. 3 years old child with 2 episodes of otitis media, delayed speech, deafness of 70 decibel, high frequency means sensory neural, next best step. And so for that, we know we already talked about ENT for the hearing aid, ENT for grommet insertion, speech therapy, or MRI. Previously, they have asked about only one step, and we go for the hearing aid. And now they have asked about the two steps. So for the second step, we will go with the speech therapy as the child is having the delayed speech therapy. So option A and the option C is the most likely going to be right answer. We do not go for grommet insertion because they said that it was high frequency is always sensory neural, and for the sensory neural we don't need to go for the grommet insertion. So option A and the option C is right here. AKP May 2018. 6 years old asthmatic on salbutamol and steroid 100 microgram BID inhaler, not controlled, what to do. So child is above 5 years of the age and taking low dose inhaled corticosteroids but not controlled. So in above 5 years, low dose inhaled corticosteroids, if not controlled, then the next step is going to be your montelukast leukotriene receptor antagonist. So option C is going to be the right one here. As you can see, between 5 to 11 years of the age, low dose inhaled corticosteroids. If option is there for MART, then you can go with the low dose. Next step will be low dose MART therapy. If patient is unable to manage MART, then the next step will be leukotriene receptor antagonist. And we don't have any option for the low dose MART, so we will go with the next step. That will be your leukotriene receptor antagonist, and that is the montelukast. A child on the SIMV on the ventilator changed to CPAP with pressure 5 and then deteriorate after 2 hours. Acidotic PCO2 is high. What to do? Shift to SIMV back if only hypercapnic, drain pneumothorax if generally unwell, poor effusion, shock, and term baby. Increase CPAP pressure but exclude. Okay, this was also again a not incomplete scenario. Scenario was there, so they don't know what was the answer. So they, as there is a hypercapnia deterioration, so they said that you will shift back to the SIMB, but we need to first exclude the dope. But the dope we only go in a sample paper, the option was check if CPAP working correctly. So if the features of the pneumothorax has been given because sudden deterioration is there, then in which patient will become unwell, respiratory distress, and duration of the oxygen saturation, then we will go with the needle thoracocentesis and the chest drain insertion. Otherwise, if there is a very high PCO2, then we will, and all the other things are normal, which then we will shift back to the SIMV. And we will dope, I don't know, exclude dope first in sample paper. It was check CPAP working correctly. So according to the scenario, you know that whenever child is on, if we shift on the CPAP, we don't know it's through the like nasal or it's still through the your CMY, like through the ETT. So according to that, whatever scenario has been given, explained in that, you need to go for that. And whether there is any blockage of the tube, whether there is any obstruction of the tube, any pneumothorax is there, equipment failure is there. If everything is normal, then you will shift back the patient to the CMV still if there is hypercapnia. So that was all for the respiratory and the ENT recalls. And if you got any other recall, which I have not entered that, then you can just ask me in the group and then I will explain it there. And if any here, any one of any scenario is not more clear to you and you want a further explanation, then you can just also put it in the group and I will explain it there. So thank you so much and Allah Hafiz.